ਆ ਤਾਂ ਨਹੀਂ
ਓਕੇ ਓਕੇ।
ਪਾਇਆ ਨਹੀਂ ਧਿਆਨ ਦਿੰਦੇ ਤੇ ਜੋਲੋ ਜਦੋਂ ਮੈਂ ਬ੍ਰੇਕ ਹੁੰਦਾ ਸੀ ਤਾਂ ਵੀ ਬ੍ਰੇਕ ਪਾ ਦਿੰਦਾ ਸੀ, ਜਦੋਂ ਮੈਂ ਬ੍ਰੇਕ ਹੁੰਦਾ ਸੀ ਤਾਂ ਵੀ ਬ੍ਰੇਕ ਪਾ ਦਿੰਦਾ ਸੀ। ਉਹਦੇ ਉੱਤੇ
ਪਤਾ ਹੀ ਜਰਾ ਜੀ ਚੀਜ਼ ਇੱਕ ਵਾਰੀ ਹੱਥ ਚੜ ਜੇ ਨਾ, ਪਤਾ ਹੀ ਜਰਾ ਜੀ ਚੀਜ਼ ਇੱਕ ਵਾਰੀ ਹੱਥ ਚੜ ਜੇ ਨਾ।
ਹਾਂ ਉਹ ਚੱਲਦੇ ਫੰਕਸ਼ਨ 'ਚ ਵੀ, ਹਾਂ ਉਹ ਚੱਲਦੇ ਫੰਕਸ਼ਨ 'ਚ ਵੀ ਬ੍ਰੇਕ ਪਾ ਜਾਂਦਾ ਸੀ ਵੀ ਹਾਂ ਵੀ ਵੇਟਿੰਗ ਫॉर ਲਾਈਵ ਜਾਂ ਕੋਈ ਨਾ
ਬੰਦਾ ਸਟਿਲ ਲਾ ਦਿੰਦਾ ਵਿੱਚ।
ਹਾਂ ਹਾਂ ਕਰਤੀ ਸਰ, ਕਰਤੀ ਕਰਤੀ ਸਰ, ਕਰਤੀ। ਕਰਤਾ ਇੱਕ ਵਾਰ ਲੈਵਲ ਬਹੁਤ ਹੈ ਦੇਖੋ ਬਹੁਤ ਹੈ ਓਕੇ ਜੀ ਓਕੇ जी ठीक है जी ठीक है तेरे से तो छुट्टी हो गया मैं पहले पता लगा कहते कि नहीं कुछ लगता है
in medicine begins where curiosity meets commitment.
Good morning to our respected dignitaries, honorable chairpersons, distinguished speakers, esteemed faculty members, and my dear colleagues.
It is both a privilege and a profound honor to welcome you all to this exceptional gathering of minds dedicated to advancing the science and art of healing.
Today is not merely a conference, it is a confluence of experience, innovation, and purpose. Each session is an opportunity not only to learn, but to refine the way we think, the way we practice, and the way we serve humanity.
Today, I, Suknoor, alongside my colleague,
Gun Goyal,
third-year MBBS students at IIMS Bathinda, are honored to guide you through the final day of this academic journey. Now, let us begin this journey with a warm round of applause as I invite the distinguished chairpersons for our next session. Dr. Anupama Agarwal, Senior Gynecologist at Navjeevan Nursing Home, Dr. Arvind Sharma, Senior Gynecologist of Bathinda, Dr. Monica Kapila, Senior Gynecologist at Kapila Hospital, Bathinda. We welcome you, sir and ma'am. Pregnancy represents both physiological brilliance and clinical responsibility. To guide us through this delicate balance, we invite Dr. Ashrama Taneja, Professor and Head OBG at DMCH Ludhiana. Ma'am, your work continues to safeguard two lives at once, mother and child. We invite you to kindly deliver your talk.
So, good morning all. Thank you to the Bathinda Society, Dr. Arvind Sharma and the rest for giving me this opportunity. The medical disorders in pregnancy. So there are a lot of medical disorders, but I thought I will take up the medical disorders which we commonly see in pregnancy: anemia, gestational diabetes, hypertensive disorders, and thyroid dysfunction. So let's look at anemia. So the survey says that the incidence of anemia in pregnancy is somewhere close to 52%, which is quite high. And India accounts for 80% of the maternal deaths. So it is our moral duty to take care of this incidence and this mortality. How can we do that? We have to know the normal levels of hemoglobin. Only then we can do a prevention and a treatment for anemia. So WHO says that anemia is less than 13 gram% in men. In non-pregnant, it is 12 gram%. But pregnancy is different. So here the levels are 11 gram%. Less than that, we call it anemia. In anemia, the most common cause is an iron deficiency. But there could be a concomitant folate, B12 deficiency. There could be a hemoglobinopathies. There could be chronic diseases like hookworm malaria. There could be acute diseases leading to bleeding. So why are we discussing iron deficiency, particularly in anemia, in pregnancy? Iron deficiency is common in pregnancy because increased iron needs, because the blood volume increases, the RBCs increase, and this is what is required for the fetal and the placental growth. Symptoms of anemia in pregnancy remain the same. It could be extreme weakness, it could be headache, it could be chest pain, shortness of breath, the patient looks pale, there could be numb or cold feeling, irritability. So the symptoms in pregnancy are almost the same. So once the patient complains of the symptoms, we do the HB levels and then we categorize whether it is mild, moderate, severe or very severe depending on the hemoglobin levels. I said that less than 11 is anemia. So mild is 2 to 11, moderate 7 to 9 gram%, severe 4 to 7 gram%, and very severe less than 4 gram%. So why do we need to take care of this anemia? Because there are maternal and fetal complications. Maternal can lead to heart failure, postpartum hemorrhage, and need of blood transfusion. And the fetus also suffers. There could be fetal growth, low birth weight, and other problems. So what do we do? So we should have a protocol. When do we do the HB estimation in pregnancy? Government says that whenever patient comes, whether twice a week, whenever she comes, every visit should be a HB gram hemoglobin estimation should be done. But in private practice, we cannot do the same. So we need to figure out my subsequent slides. Look for the symptoms as I told in the previous slide. What is the cause of anemia? Whether it is a multiple pregnancy, a teenage pregnancy, short interpregnancy interval, poor nutrition, or anything causing acute or the chronic blood loss. So if we go by the guidelines, so we do the HB estimation in the first trimester of pregnancy, then we can do at 24 to 28 weeks, and then 36 weeks. So in private practice, at least we can get 3 estimation of the hemoglobin. But our Foxy Society suggests that if we could do a CBC rather than only HB, we get the RBC indices, we can get a peripheral blood evaluation so that we get to know what type of anemia it is and we can differentiate from a megaloblastic anemia or a chronic disease. So as soon as the patient comes, rather than a HB estimation, CBC and a peripheral smear can be done as suggested by the various authorities. Along with that, hemoglobinopathy thalassemia is very common. So in the same sitting, we can get a HB electrophoresis or high performance liquid chromatography to rule out thalassemia. So we should do 2 tests, CBC and a thalassemia screening, as soon as the patient comes to us. So how do we manage till we have the reports? We have to give iron and folic acid to all the women. So what is the dose? It is 60 milligram elemental iron and 500 mcg of folic acid. You have to start from second trimester, at least cover 180 days of pregnancy to be continued after delivery for at least 180 days. When the HB level is less, do deworming and avoid this albendazole in the first trimester. You can start from the second trimester. Along with that, counsel her about the iron-rich diet, consumption of vitamin C, and avoid tea and coffee around the iron intake. When the patient comes to you, whenever you give an iron tablet, tell her that there should be a gap of at least 1 hour after the meals so that the absorption is maximum. So we learn from here iron, folic acid, deworming, vitamin C, and avoid the products which decrease the absorption of the iron. In pregnant women, if there is mild to moderate anemia and the gestation is 30 to 32 weeks and responding to oral iron, you can continue that. Otherwise, you can take a decision of the IV iron as well. So this is the picture showing that the government is promoting the iron and folic acid freely available in government hospitals. Anemia Mukt Bharat. So Government of India is giving tablets which suggest that 60 milligram is enough. But here we have Anemia Mukt Bharat. These guidelines were framed in 2018. They suggest that you can give 100 milligram of iron. So the previous milligram of elemental iron. Otherwise the duration is the same throughout the pregnancy and to be continued after delivery. Now is the treatment. The previous slide suggested that even if we don't have the HB levels, we give prevention to all. But once we have the HB level, we have categorized as mild, moderate, severe, and then we decide how to go about it. So if it is mild and moderate, we've already discussed we give oral iron. So you can give 60 milligram or 100 milligram. You can give morning, evening. You can increase the dose along with the diet, what we suggested, and deworming. So you can get a repeat HB after 1 month to see the response. But if it is moderate to severe and she's not responding to oral iron, try giving IV iron. About IV iron, I have the subsequent slides. I'll let you know which is the best. If it is very severe or there's a compromise, we give a blood transfusion. This study was done in PGI where they compared whether ferrous sulfate should be given, ferrous fumarate should be given, ascorbate, and the carbonyl iron. So the market is flooded with iron. Government prefers giving ferrous sulfate in the government hospital. So should we give ferrous sulfate or can we switch over to a expensive ferrous ascorbate or carbonyl iron? Ferrous ascorbate and carbonyl iron, they have less GI side effects, but they are little expensive. This study was done in 2021 in PGI where they found you can give any, but the sample size was very less. 30 patients received ferrous sulfate, 30 received fumarate, 30 ascorbate and carbonyl iron. So they concluded you can give any of these. If we have to give IV iron, this is the standard formula which is given in our books, Genzoni formula, where we calculate the dose of the IV iron plus the iron for stores are calculated and given. So the formula is the same, but what about the drug? Which IV iron to be given? So earlier traditional reading was the iron sorbitol and the Jectofer, but nowadays, after all the meta-analysis and all, we have found out that ferric carboxymaltose is the best. It is superior, less side effects and better efficacy. After you have given this, you repeat the HP levels after 2 weeks, it will show a rise. If the rise is not sufficient, you can repeat a dose after 2 weeks. And you have to hold oral iron for at least 2 to 3 days, because if there's a chelation of IV iron with the oral iron, then the effect will be less. So in India, we have the oral tablets, we have the IV iron also, but what we need to adhere is the compliance. We should make sure patients do take iron tablets at home and they are treated with helminth or any other infection and they continue in the postpartum period. So which is recognized first time during pregnancy. Pre-gestational diabetes. So we don't call it a overt diabetes. The terminology is pre-gestational. As the name suggests, it was there before the pregnancy. It could be a newly diagnosed during pregnancy as well, and that we diagnose after doing the estimation of the blood sugar levels. Otherwise, whenever you diagnose for the first time, it is gestational, but if levels are really high, we can call it pre-gestational. So as I said that the tune in India, it is up to 10%. In United States, it's 7%, but in India, it varies in different regions. The weighted national prevalence is to a tune of 22.4%, as one of the ICMR studies said, but the average is 10%. So what are the signs and symptoms? Anemia, we know whatever was there in a non-pregnant patient. Similarly, in gestational diabetes, there are no unusual symptoms. It's the same as diabetes. You can ask for increased thirst, increased urine, extreme hunger and irritability. What we need to know as Asians, we are at high risk. So all the mothers to be screened for glucose screening as we have done for the anemia. But on top of that, the high risk factors we have to know: any patient who is obese, BMI more than 25, low concentration of HDL7, previous history of gestational diabetes or adverse outcomes in obstetrics, abnormal oral glucose tolerance test. Even if you don't remember this, as an Asian, you have to screen for all the patients. We are at high risk. Why do we need to screen? Because they have maternal and fetal complications. Mother can have a concomitant preeclampsia to a tune of 25%. And along with that, there could be polyhydramnios, multiple infections, and because of macrosomia, operative deliveries are high. And then later in life, she can progress to diabetes mellitus. Fetal can be macrosomic. The baby can suffer shoulder injuries and birth trauma at the time of delivery. And once the baby is born, there could be respiratory distress and admission to NICU. So we do not want all these complications in the mother or the fetus. So what do? We have various guidelines, but we follow the guidelines which is prevalent in India. So we follow the DIPSI criteria. So what is that? It is a single step. Earlier guidelines suggested that you can do it as a 2-step, but our patients do not come over and again. And our patients do not come fasting for a visit. Whenever she is there in the antenatal OPD at the same visit, irrespective of the meals, we can get this tested. So looking at our population, this is a very good step. You give 75 grams of the oral glucose and test test her blood sugar levels after 2 hours. If it is more than 140 milligram percent, then we label the patient as gestational diabetes. So there's only one test. Whenever the patient goes to the laboratory, the lab person sends her back saying it has to be a fasting test, but this test is irrespective of the meal. Anytime she visits your OPD, give her a challenge of 75 gram. We have the special packet sachets of G75. Earlier we were giving Glucon-D, which was not accurate. So we have the specialized packets of 75 grams of glucose. You give that to the patient and after 2 hours, get a plasma level. If it is more than equal to 140, you can label her as gestational diabetes. Though the sensitivity will be definitely less if we do a fasting and a repeated testing, the sensitivity will be high. But looking at our population, this is a single best test. So once we have seen that this is more than equal to 140, what do we do? Though we have other tests to find out what are the maternal and the neonatal complications, we come to the treatment straight away. What do we tell the patient? So since this is a gestational diabetes, the foremost thing is the exercise and diet. With this we can control, so there's no need of a pharmacotherapy for the first 2 weeks. So you tell her that she can go for walk, she can exercise, and she has to have a diet according to her BMI and the calories. So if she takes the lifestyle modification and medical nutritional therapy, she tries for 2 weeks, and after 2 weeks you can check her postprandial sugar levels after 2 hours. If they are well controlled, the patient should continue the same. If they are not controlled after 2 weeks, then you can go for the pharmacotherapy. So the best is the insulin to take care of the diabetes in pregnancy. But some patients don't have the compliance, they're coming from the far areas, then you can consider giving metformin. Metformin has found out to be safe and effective, but the drug of choice is insulin. The fetal surveillance and delivery planning along with the gynecologist. What about the postpartum? This is important. If the patient comes to you in the postpartum period, she has to undergo a test, which is again an oral glucose tolerance test at 6 weeks. Now this 6 weeks test is not the same what we did in pregnancy. Here she has to undergo a fasting blood sugar. After that she consumes 75 gram and after 2 hours she gets the blood sugar. So we have two values in the postpartum period. This is very important because she can become a diabetic later on. So she has to get herself tested at 6 weeks, 6 months and 1 year. So you cannot leave the patient alone. You have to give her a good guidance. We move on to our third medical problem, hypertensive disorder. Again, the tune is around 9 to 10%. Now we have a different terminology in pregnancy. Chronic hypertension, when her blood pressure is high, less than 20 weeks. Gestational hypertension, when the blood pressure is high after 20 weeks, but there is no proteinuria. So along with the blood pressure, you have to have a urine test. Urea is present or not present. Preeclampsia, hypertension with proteinuria, and or maternal organ dysfunction or uteroplacental function. So gestational hypertension becomes preeclampsia if proteinuria is present. If with preeclampsia she throws a fit, it is eclampsia. Superimposed preeclampsia on chronic hypertension. Now chronic hypertension is going to develop less than 20 weeks. So patient who is hypertensive less than 5 months and after 5 months there is a steep rise of blood pressure or a newly onset proteinuria. So a superimposed preeclampsia on chronic hypertension. So chronic hypertension was already there less than 5 months and after 5 months the BP increases and proteinuria appears, which is called superimposed preeclampsia. So whenever patient comes to us, we have to give a category to what classification she belongs because the treatment lines are different. So the foremost thing is starting with the BP. So we have to measure the BP in a correct position. So I'll move on to my next slide to see the 7 simple steps. So what happens in our OPD, sister is talking to the patient and she's taking her blood pressure. So make sure you do not converse with the patient. Patient भागता भागता आया, लाइन में लगा हुआ है, मेरी टर्न आ जाए, मेरा BP चेक कर दो. So you have to make sure that the patient is at rest for at least 5 to 10 minutes before she gets her blood pressure checked. You have to make sure that she's not smoking outside. बाहर speaker आई है, सुता पी के आई है और अंदर BP कर दिया. So these will give erroneous results. You have to make sure tea, coffee intake is not there prior to taking BP. And she is sitting comfortably on the chair with the arm at the level of the heart. So if we take care of these few tips, we can measure the BP appropriately. And the cuff also. You should have 2-3 categories of the cuff. If it is an obese patient, use a larger cuff. If it is lean and thin, use a smaller cuff. If the cuff is not appropriate, the BP readings will not be accurate. So even in spite of doing all this, the BP is high. So you have to repeat that again. Maybe if you are in the OPD, you can repeat after 10 minutes. But if it's IPD patients, you can take a liberty. Now what is this high BP? So we consider 140/90 as high BP. And if 140/90 appears again after 4 hours, we label her as gestational hypertension. So we need 2 readings, 4 hours apart, to label as gestational hypertension. But if you are in the OPD, try to settle the patient for 10 minutes and repeat after 10 minutes, because your OPD patient will not sit for 4 hours. So if BP is high, you can admit and repeat after 4 hours. Warning signs. Warning signs are just few. You have to find out if she's having headache along with the BP, any blurring of vision, any epigastric pain, or any urinary discomfort, any urinary output which is less. There could be some cerebral features, like she could be dizzy, there could be some aura, but those are rare features. So the important ones are the same as you ask in a non-pregnant patient. So why are we so concerned? Again, there are some maternal and fetal complications which can happen, so we should not let the BP rise. We should treat adequately. So the maternal complications, the short term. So the leading causes of mortality in females is anemia, and the second most is hypertension. So mortality is very common. She can have a heart problem, MI, stroke, cardiomyopathy. She can have a coronary artery disease, and after delivery she can end up in PPH and shock. Long term, she can develop hypertension, diabetes, stroke. Short term, as suggested earlier, it could be FGR, stillbirth, or a preterm delivery. So these patients, when they come to our OPD and they're less than 16 weeks, we should identify these patients, because if we can start aspirin less than 16 weeks, we can take care of so many problems. But if we cross this landmark of 16 weeks, then we can end up with problems. So how much aspirin to be used? 75 milligram, some societies suggest you can use 75, but fetal medicine suggests 150 milligram. So this has to be given at bedtime, because it causes a lot of nausea. So if you are not able to, if the patient is not able to digest 150 milligram, she can be given 75 milligram. But 75 and 150, the efficacy is the same. It will be handling the same problems in a similar way. So management, so I have to hurry up with my slides. So we have to know what are the drugs which can be used for simple hypertension, for gestational hypertension, for hypertensive crisis. So in pregnancy, our drug of choice is labetalol. And in hypertensive crisis, we can give hydralazine or we can give IV labetalol. Timing of delivery is according to the gynecologist. So the underlying thing is save the mother first, and severe range of BP is an emergency. Please try to admit these patients even if the BP is not high, because we can save these lives. My last topic is the thyroid disorders. So thyroid testing has been now as a part of a universal screening. We inform all the pregnant patients that this has to be done, because this can lead to miscarriages. So thyroid disorders are prevalent again to a tune of 10%. So there could be a hypothyroidism or a hyperthyroidism. And what is important is an early diagnosis. As I suggest, aspirin was at 16 weeks. The thyroid disorder has to be diagnosed by 7 weeks. If you miss this, the patient can end up with miscarriages. Hypo and hyperthyroidism, I'm not going into the details of the symptoms. What we need to know is, if hypothyroidism is untreated, miscarriage is the first trimester, very important. Don't miss this 7 weeks. She can have anemia, preeclampsia, abruption, preterm birth. Similarly, hyperthyroidism is also related to preterm birth and fetal growth restrictions. Now the standard guidelines are that you have to know that the first trimester TSH level should not go beyond 2.5. Sometimes we get the values 3.8, 4. What do? We get the antibodies tested. If antibodies positive, treat. If antibodies negative, don't treat. That means TSH level more than 2.5 in first trimester, but TPO negative, don't treat. But if TPO positive, treat. Second and third trimester TSH levels are 3 milli-international units per liter. And pregnancy is a state of hypothyroidism. So we have to limit ourselves to this. If the TSH levels are more, you have to increase the dose by 30%. Postpartum, now she delivers. What happens? After delivery, again you have to do TSH levels at 6 weeks. Patients of overt hypothyroidism, their dosages are same in the postpartum period as it was there before pregnancy. But subclinical hypothyroidism, patients who started their thyroid disorders in pregnancy, their dose have to be decreased by 25%. So any patient who's taking thyroxine 50 and was diagnosed in pregnancy, this dose has to be stopped and the patient undergoes a TSH level at 6 weeks. But a patient of overt or subclinical hypothyroidism taking more than 50, the subclinical hypothyroidism, the dose has to be decreased by 25% and overt patients will take the same thyroxine as she was taking before pregnancy. So I will skip these slides. So what is important is checking her blood pressure of all the pregnant patients, getting her HB estimations, getting a TSH done, and a glucose screening test. With this, we can avoid all the maternal and the fetal complications and have a safe delivery. Thank you.
Dr. Ashima, for such a beautiful, short and sweet revision of all the medical disorders. And what I think, just few simple steps in our OPD can save most of the patients, especially and getting thyroid check at the first visit. And we get so many patients who are hypothyroid and they don't know about it. Simple thyroid checkup at first visit of the patient estimation. That helps us in treating almost all the complications in pregnancy. And once you catch the BP early, as ma'am has said, aspirin helps a lot. Adding aspirin later on in the pregnancy doesn't help. So get your patient's BP checked accurately by a trained staff, not a hota gaya nawa staff hai to BP check kar le. BP checking is considered as a menial job. I think it is the most important job. And once you get patients' symptoms like high BP, it is good you check for yourself. जिन भी पेशेंट्स का बीपी ज़्यादा आ रहा है खुद चेक कर लो एक बार. So that is a good thing to do. Thank you, ma'am.
Thank you so much, ma'am, for such an elaborate and you have touched all the topics very nicely. Anemia is part and parcel of everyday practice. We are doing all the testing, CBC, PBF, even thalassemia screening. One thing which we come across very commonly in spite of all this is gluten sensitivity. Patients are not responding. When you check for wheat allergy, they are positive for that. That is also very commonly coming up in this area. So we can test for that also.
Yeah. So any patient who is tested for malabsorption, IV iron should be a good option rather than giving an oral.
Yeah, these patients they respond very nicely to IV iron. And a regular antenatal checkup. All these patients, they fare very well. So regular screening, antenatal checkup, all the conditions can be managed very, very well.
Now I request Dr. Amit Agarwal, laparoscopic surgeon at Navjeevan Hospital, to felicitate the chairpersons.
Please, both the chairpersons, please. आप भी आ जाओ.
Thank you, sir, for your presence. Now my colleague Gwyn will take over.
Thank you, Sukhnoor. As I stand at the dais, it is my proud privilege to invite our distinguished chairpersons to preside over the next proceedings. I respectfully invite Dr. V.P. Kalra, oncosurgeon at Park Group of Hospitals. Sir, your academic excellence and dedication continue to inspire us all. I also invite Dr. Neha Gupta, medical oncologist at Max Hospital. Ma'am is a respected mentor and scholar whose guidance enriches every academic platform. I would also like to respectfully invite Dr. Saloni, assistant professor at Advanced Cancer Institute, Bathinda. Ma'am, we would be honored to have you preside over as the chairperson. We are truly honored to have such eminent personalities guiding us today. It is my great honor now to introduce our esteemed speaker, Dr. S.P. Kataria, Vice Chairman, Medical Oncology and Hematology, Vedanta Group Hospital, Gurugram. Sir is a widely respected person for his outstanding leadership, vast clinical experience, and significant contributions to medical education and patient care. Today, he will be delivering a talk on recent advances in cancer treatment. This important topic holds immense relevance in modern clinical practice, and we are privileged to learn from his knowledge and experience. With great respect and anticipation, I invite Sir.
Thank you, chairpersons. Thank you, Punjab IMA and attendees for allowing us to be here. I'm Vice Chairman Medical Oncology in Vedanta. I worked in government sector for 33 years in Subject Hospital. After retirement, I'm working in corporate now, so I'm having a taste of both kind of things. When I came here, I was told that I'll be probably, delivering a small talk to most of the physicians, surgeons, a mixed bag of people. But now I see here, Bathinda, I think, has changed a lot. And we see a lot of new things happening all over, So let me begin. When I started my career in 1991 in medical oncology, stage 1, 2, 3, 4 cancer. That's what they used to teach us. Stage 1, 2, 5%, 10%, less than 10% mostly. Curative settings are very low. 90% used to be non-curative stage 4 tumors. But gradually things have changed. From 2 to 4 months in 91, average survival for a stage 4 cancer. Now, in 2000, it became to 8 months. In 2010, it became to 20 months. And now in 2025, stage 4 cancer survival for all cancer patients, even in India, is roughly reaching 36 months. And some of the tumors which are, favorable group, good tumor markers, we have good and good targeted drugs, they are even surviving 5 years or more. So lung cancer, something like lung cancer, which was median survival used to be 2 years when we used to conduct studies. Now many of these patients are surviving 5 years. So a lot of things have changed. I remember when we used to talk about Philadelphia chromosome, it was first discovered in 1960. And then that's all it was. After 14 years in 1973 only, they found out that it is a translocation between 9 and 22. Then that's when the Kimsa staining came in. And then they found that in 1995, they found that BCR-ABL gene they were able to characterize. And within 5 years, they had a drug to block that BCR-ABL combination and literally cured CML for all patients. So things have changed in past, I think, 15 years from 2010 onwards. We have a lot of things happening, immunotherapy and targeted therapy, and of late, CAR T cell also has come into picture. So our aim is probably stage 1, 2, 3, cure all stage 1 and 2 patients with our standards, surgery, chemo, radiation. Stage 3 patients, cure 70% of them or more also. And stage 4 patients, even if they are not curable, we want to convert them into a chronic disease. That means all patients like diabetes or hypertension should be able to live for 10 or 20 years, which probably we should be able to achieve by 2030. Initially, we were planning to do that by 2030, but hopefully by 2035 or so, we should be able to make it a chronic disease. That is, patient continues to take treatment, he continues to do his normal work, and life is okay. So, we have already covered, we have taken care of cardiology, we have taken care of respiratory, nephro, everything is under control. We can do a CBG at 90 years of age, there's no problem. So cancer also is getting under control in a good way, I think. Even though treatment is expensive at the moment, but as the generics come in, things will be better. So today I just want to present 3 cases, not the horrible cases that you see on cigarette packets, but 3 good cases that feel good factor that gives you, and then maybe we can discuss how we are achieving all that at the moment. So case 1 is a 63-year-old male presented with cough and 1 or 2 episodes of hemorrhage. These are all real cases actually from the OPD. PET scan showed a left upper lung mass, biopsy proved to be adenocarcinoma lung, TTF positive, which showed a pulmonary origin. Final diagnosis, he had a stage 1. He also had liver mets on PET scan. It was a stage 4 tumor. He was not willing for chemo. His next-gen sequencing was negative for any targetable mutation. Only thing is PD-L1 was 85%. So he was given IV pembrolizumab 4 cycles. After 4 cycles, he showed a good response. You see the left one is the tumor, and after 4 months there is a good response. And because he didn't want any other treatment, he did get SBRT to the lung and residual liver lesion, but he was okay. He continued to be asymptomatic for 2 years. We stopped treatment after 2 years because we didn't know when we could stop immunotherapy. That time they were saying 2 years is good enough. When he lapsed 1 year later. So for 3 years he was fine, and but we suppose this patient was supposed to be 4 months or 6 months or 8 months median survival. He did not have any side effects of chemotherapy like hair loss, nausea, vomiting, all those side effects were not there. Very minimal side effects of immune system, primarily dermatitis, skin and hypothyroidism were there, which was controlled well with conservative treatment. Case 2 is a 75-year-old male smoker, underlying CAD, underlying CLD, evaluated for cough. Again, he had a left lung mass, multiple bone lesions. And what they did, they again did palliative RT to these bone lesions. after palliative RT to the bone lesions. After 6 months, he had a very good response to primary as well as metastatic sites. And his continued after 1 year. He was stable disease. He had a residual lung lesion for which SBRT was given to the lung lesion. And now he's 5 years. He's taken osimertinib for 5 years and he's still happy. He's still in remission. He's still in CR. And almost 80 now. Last week only he came to the OPD and still going on strong. Case 3 is an old case of mine that was in 2007. 22-year-old male. He presented with hyperleukocytosis and splenomegaly. Workup was CML chronic phase. BCRB was positive. P210. Started on imatinib 400 milligram. He achieved hematological remission after 3 months and he was in MMR at 1 year. He is on imatinib 400 milligram daily for last 18 years and he's still maintaining his MMR. He is now 40 years of age and he's doing normal work and running a normal family. So this is how things are moving and probably in the right direction. We all know about that we all are, product of stem cells, right from the fertilization point till about 6 weeks time, the fetus is only pure stem cells, and then they start migrating to various parts of the body. So you have the stem cells for normal growth and repair. This this growth and repair continues throughout our life cycle till our death. Control is important. What we control is growth and tumor, cellular proliferation and cellular overgrowth. That is important. Once they go out of control, then you get the tumor formation. If you see this is actually a cell diagram. What we see here, that we have the membrane, it's a phospholipid membrane, we have the nucleus in the middle. And for any antigen that we are exposed to in the life, the cell will have a receptor to that. This receptor is again three things. It has the extracellular domain, it has the transmembrane domain, it has the intracellular domain. Now this receptor is developed by the cell. All T cells and all B cells initially will develop this receptor on the surface of the cell. Once the antigen is internalized, it will activate our genetic cascade. The enzyme systems that are responsible for growth and repair or tumor formation. This is a very actually less than 5% of the tumor producing systems in the cell that are active at any point of time. PIK3CA, RAS, RAF, BRAF, growth factors like GCSF, EGFR. All these are the receptors that are present on the surface. Once they get overactive, then the tumor, they will actually send signals, transduction signals to send the signals to inside the nucleus, and then the gene will become overactive again under these surfaces. So if the tumor cell is not ready for division, is defective, then the immune system or our tumor suppressor gene will try to kill it by apoptosis. They activate the caspase pathway. So this is how it has moved. I remember in 70s and 80s how missing one small lymph node, one small spleen will fail your exam. But now we have the imaging, we have the MRI, we have the PET scans, we have the radioisotope labeled scans again. Pathology with all its immunohistochemistry is aiding a lot to identify the cell of origin. We have the tumor markers like alpha, fetoprotein, beta hCG, CA, CA19.9 that gives us an idea, CA125 that gives us an idea that this tumor is secreting these markers. And finally the genomics. Nowadays we are taking all the tumor tissue and we are amplifying all the genes and see which is more active, which is less active, which is producing more protein. Once we identify the protein, it's easy. We can get a drug in about 3 to 5 years with our antisense technology. So we are, as I mentioned, chemo, we could, even in India, I think we could cure stage 2 and 3 cancers. Cure rate was only 30% with surgery, chemo and radiation. Newer drugs are making a change now. As I mentioned, targeted drugs that actually act on the receptor sites are two groups mainly, monoclonal antibodies and we have the small cell molecules. Monoclonal antibodies are basically proteins. They have these heavy chain and light chain components. They are attached to the extracellular domain of the receptor. Then it is internalized and it will block the signaling cascade down to the nucleus. Whereas the small molecules, they will be internalized first and then block the intracellular domain to block the erring gene. That is the one that is causing the tumorigenesis. We have number of groups. We have the BCR-ABL, we have the EGFR inhibitors, we have the VEGF inhibitors, we have the mTOR, we have the multi-targeted drugs. And nowadays we are trying to get this combination of these two. That is, you get the antibody and then you attach to it with a cytotoxic drug with a linker. So you have these ADCs, antibody drug conjugates, that will be internalized and the drug will be released only inside the tumor cell. That is a targeted drug and will cause the destruction of the tumor cell and probably some surrounding tumor cells also, bystander effect. We have a number of drugs which are available: bevacizumab, tocilizumab, cetuximab, trastuzumab, rituximab, panitumumab. You know, they are all active against surface receptors and are specific for those particular tumors which are expressing these receptors. Small molecules, we have seen in lung, we have excellent number of drugs. We have had the CML ones. CML, we have the imatinib, nilotinib, dasatinib, acinib also is now available, ponatinib is also now available. For lung, we have the initial ones, the geftinib, erlotinib. Now we have lorlatinib. Oh, sorry, lorlatinib is for ARC, but osimertinib and apotinib is available for EGFR19. Imatinib, as I explained earlier, it was the first targeted drug that literally cured. Median survival now is 25 years for CML patients. Almost 80%. Only about 10 to 15% will develop some resistance or they will not be able to tolerate imatinib. So those patients can be offered the other newer BCR-ABL inhibitors like nilotinib, dasatinib, sunitinib and asciminib. Crizotinib is again an ALK inhibitor which is used in non-small cell lung cancer. Again, now we have almost 7 years data for crizotinib and lorlatinib because ALK inhibitors also respond very well to these targeted drugs, lung cancer patients. So we literally, half of these patients are surviving for 5 years. Lapatinib is a HER2 inhibitor that is used for breast cancer. After patient has failed trastuzumab as pertuzumab. And now we also have got the, again the new one, trastuzumab deruxtecan, that is a new drug on the block that is very effective even for low HER2 positive patients also. Vascular growth factor inhibitors, they will block the tumor vessel formation, arterial blood vessel formation inside the tumor, so the blood supply is reduced and ultimately the tumor cell will go necrosis. Bevacizumab and aflibercept are the drugs that are available. They are useful for brain tumors, useful for lung cancer, useful for colon cancer, and useful for hepatocellular carcinoma. Earlier, as I mentioned, ADC is antibody drug conjugate. You get an antibody that is like trastuzumab, then you get a cytotoxic payload and you attach the drug with a linker to the payload and it is delivered to the inside the cell. So what it does, it delivers inside the cell, so the normal toxicity of this cytotoxic drug to the rest of the normal cells is not there. Good example of this is the one in rituximab vedotin, which is used in Hodgkin's lymphoma. It is available for first-line treatment now. Cure rate is almost 80 to 90% with this drug, used even in relapse setting. And TDM1 is another drug that is used, that is a HER2 receptor antibody drug conjugate used in breast cancer patients after failure of trastuzumab and pertuzumab. So TDM1 has a antibody and a cytotoxic drug, that is antacid, that destabilizes the tubules so that the cell is not able to divide and he undergoes apoptosis. So differences are these target drugs is that normal chemotherapy side effects are not there. The dreaded side effects which earlier used to be there, they are not there with these patients. They are mostly skin, diarrhea, and hepatitis. Mostly these things we are, but if you monitor them well, if you are able to detect them early, and if you say reduce the dose or stop the medicine for some time, we should be able to manage all the side effects very well. Immunotherapy is a new thing. How it works, we know that our immune system, normally in our body, approximately 1,000 tumor cells are produced on a daily basis. And they are all removed by our immune system. It will recognize immune system, our T and B cells will recognize that foreign, and then it will be eliminated. But tumor cells, once they overwhelm the system, they are also very smart. What they will try to do is they will try to develop a ligand. The tumor cells will overexpress a ligand, PD-L1. It's a death cell receptor ligand. It will be overexpressed on the tumor cells. So it will go and attach to the T cell PD-1 receptor that is normally present. Or it will put it off. So it will not be able to recognize the T cells. Recognize the T cells, so it will not kill. So it will switch off the T cell. They are less effective. Immunotherapy, what they did was they tried to, because they already separated it, they already characterized it molecularly, and they found an antibody to it. So they tried to block the PD-1 ligand. So we can block both, either the PD-1 receptor on the T cell, or we can block the PD-L ligand on the tumor cell. Once you block, this tumor cell is not able to switch off the T cell. So our T cells, normal T cells, will go and kill the tumor cell itself. Looking at the history, even in 1870, this concept was there in somebody's mind, Dr. Kohli. Whenever he operated on sarcoma patients, he gave them the dead bacterial antigen extracts. And he showed that, one moment. And he showed that it reduced the chances of recurrence and it reduced the growth of metastatic tumor sites. Ultimately, it landed up with Dr. James Allison. He was the one who got the Nobel Prize a few years ago. And if you see this PD-L1 expression, MSI testing, and they can tell us whether this tumor is going to respond to immunotherapy or not, so we can select out our patients. So patients with high T cell infiltration, high PD-L1 expression, high tumor mutational burden are likely to be responsive to checkpoint inhibitors. And it is available in commercial, available for use in various cancer cells in our body. Indications and molecules are there, and every year new molecules are also coming with new indications. This is that lady Sharon Belvin, who was diagnosed as a melanoma case in 2004. She got multiple lines of chemotherapy. In 2005, didn't respond. Then they came with the first trial with immune checkpoint inhibitors. She got 4 doses in 2006, and after that she is in remission. So and she is a very good, now doing very good social work, media and this thing. So she was the one who was, probably we have more work to do. Adverse events we mentioned already. That normal T cell will be able to kill the tumor cell if it is able to recognize it. If it is not able to recognize, the tumor cell will escape. But CAR T cell, what they are doing a engineering, reverse engineering. That is, they are inserting a virus with anti-CD19 antibody into the T cell. So, and you give 5 billion number of cells and inject it into the body. And whenever they see the tumor, it's a living cell. It will be there in the body throughout the time. Only one time injection. So you take out the T cells, and then you centrifuge it, you expand them, activate them with interleukin-2, transduce them with a virus with anti-CD19 antibody, and then inject it back into the patient. Takes about 3 weeks. Cost is about for 70 lakhs, I think, in Indian corporate sector, probably 30 to 40 lakhs in Indian government sector also. Because that virus and the vector has to be imported from outside. It is approved for relapsed B-cell ALL and non-Hodgkin's lymphoma in India at the moment. In outside countries, I think myeloma is also approved. Number of CAR T-cell vectors are available. Thank you. I think with this I will end. Any questions we can take.
Thank you, sir. An important announcement just before we move ahead with the questions. There are two cars, Fortuner 2455 and Micra 7079. They are standing just besides the electric room. Please remove. जिनकी भी ये कार है, Fortuner 2455, Micra 7079, 7079 2455. इलेक्ट्रिक रूम दे के खड़ी है, प्लीज रिमूव कर दो, साइड पे करवा दो प्लीज होती.
Nice presentation, sir. No doubt these therapies are changing the scenario in cancer treatment, but only factor that hinders is cost effectiveness, I think. What is your opinion?
Yeah, I think our Nivolumab is already there. Our generic Nivolumab is already there. We have no way, like they have invested so much of money. First 20 years of their patent, they will have all the rights. But I think even when this patent was not there, for India specific, they used to have these PAP programs that used to make it slightly more, more affordable. Like, something like a molecule which used to cost 6 lakhs in Europe or Australia, it will be something like 90,000 in India. With PAP, because with each month therapy, they will give 3 months or 2 months therapy free. So that way, companies are also there, but the cost at the moment, it's prohibitive. I agree that 90% of Indian population will not be able to afford this.
Anyhow, these therapies are reducing burden on surgical and radiation rates.
Thank you so much, sir. As we all know that because of advancement in the treatment in molecular oncology, now the treatment is basically precision based.
Yes.
Only based on targets and videos and markers, we suggest the chemotherapy and immunotherapy and targeted therapy based on that status. Yes, cost is a problem in our setting because patients are not that affordable to take immuno and targeted agent as well. But because the biosimilars is available now, it is now easy to explain the patient and convince them to take them. Because the response rates are huge difference in the response rate.
Yeah, I mean, suppose you have a sarcoma patient. It doesn't respond to any chemo. Whatever you give, 2 months, 3 months, 4 months, and then it'll still start growing again. You do NGS, you find a BRAF mutation, and you have a drug for that. And the tumor just disappears. So for 8 months, 12 months, he'll be like, asymptomatic. But the thing is that cost, I agree. But then we also have to improvise. Like, you do Guardant, you do Foundation 1, it will cost you 3 lakhs, 4 lakhs just for testing. But if you are able to do a, limited number of panel of genes with RT-PCR, probably you can do the same result you can get in about 30 to 40,000 also rupees.
Thank you, sir.
Yes.
Thank you, sir. It was a very elaborative and illustrative talk, including all the intercellular mechanisms as well. Just a small comment because we are talking about the recent advances in cancer management. So, because these days we all are talking so much about AI. So recently I heard about some new apps which are AI based, which are, one of them is just approved by FDA for the surveillance and management of the prostate cancers like Ultra AI. So what is your experience with that, sir?
No, they are coming to India also. Actually what they are doing nowadays, it is so much that you do using hemotoxylin stain. One slide. They just need one slide. They will do normal Giemsa stain on that. And what they do, they will retrospectively, they will check for another 1,000 samples with NGS. And with one slide, they will, NGS will have approximately, good NGS should have at least 500, broad panel should have at least 500 genes. These people will test 1000 genes, 1000 samples, 1000 genes, and they will simply map it to that one slide which they got, say 20 years ago. Even that also they are able to say. And they say, we can do your NGS on this slide without taking any more tissue and without doing any this thing, without doing PCR polymerase chain reactions for 1000 odd patients. So that with one slide, AI will be able to tell us what exactly is any mutation, is it overexpressed or is it underexpressed, or it is producing more protein or less protein. What they will be able to give us. Maybe another 5 years we'll get some more data for that. But AI is coming everywhere.
Thank you, sir.
Thank you so much, sir. Please stay on the stage.
Thank you, sir, for transforming clinical protocols into clarity and confidence. May I now request our esteemed chairpersons to kindly felicitate Dr. S.P. Kataria. I now take this moment on behalf of everyone to thank our esteemed chairpersons. May I request Dr. Akhtar Singh Gill to kindly felicitate our chairpersons as a token of our deep appreciation. Let's give a big hand to them.
Thank you everyone, chairpersons and the speaker. Before we move to the next session of Dr. Sushil Kotu, interesting topic of obesity, I would like to request Dr. Usha Goyal to come on the stage. We have an important message from state of Punjab, from Health Ministry, regarding Ayushman Bharat digital scheme. Dr. Usha is District Health Officer at Civil Surgeon Office, Bathinda.
A very good morning. Sorry for the interruption, but interruptions are bound to happen in between scheduled programs. But since this is a state program and we got guidelines from the state, you all know since yesterday we have put up an Abha ID stall outside. Our state team is in fact over here, guiding all the doctors who have all the health facilities to get themselves registered and make an HFR so that all the clinics, nursing homes, hospitals are registered on the portal, and then you can utilize this Abha IDs. So I have got 4 slides. I'll not take much time because we have a visit scheduled by our Honorable Health Minister at our district hospital, so I have to reach there also. Bear with me for only 5 minutes, and sorry Dr. Kotu for the interruption. So Ayushman Bharat Digital Mission, it is actually transforming India's healthcare through digital technology. So we are all moving towards digital India. So the health sector, we had to go in towards digitalizing everything. We all know when we move we go to other countries, we say everything is digitalized there and we don't need to keep your reports, your medical record, your history, because everything is on the portal on your IDs. So this was launched by National Health Authority on the 27th of September 2021 under the Ayushman Bharat Yojana, and the aim was to create a nationwide digital health ecosystem. What were the main objectives? It was to create a digital health ID for every citizen. Our patients have their health Abha IDs made from Abha IDs made from your registered phone. They generate a token. This is what we are doing in all the government hospitals now. So that, reduces that the queue, you have to be there, the waiting time for the OPD slip that has to be made. You just go, speak out your token number and your slip is in your hand, because your details are already there in the OPD slip and the patients get. So we have got rid of those long queues that we all had in the OPD, especially Bathinda District Hospital, because we have the maximum OPD in the state in District Bathinda, approximately around 1500 patients daily that we are having in Bathinda. So this also secures storage of digital health records and earlier known as Health ID. Healthcare Professional Registry, or the HPR. It is a database of doctors which includes nurses and healthcare workers. It also improves trust and verification, supporting digital consultation services. Database of health hospitals and clinics. I'm talking about HFR now. This includes all labs, pharmacies, standardizes healthcare information and enhances service transparency. Personal health record. Citizens can all store their personal health data there digitally, like we have our bank accounts all digital, so your health record will be digital here. You can access it anywhere, anytime. God forbid you meet an accident, a medical emergency, you are there in the hospital, you don't have your record, here you have it with you because it is digitally stored and safe. You can share your data with your doctors whenever needed, and it also ensures patient control over data. The benefits are an easy access to medical records, better and faster diagnosis. It also saves time and cost, reduces repeated medical tests, and promotes transparency and accountability. What are the conclusions? It is a revolutionary step in digital healthcare, strengthens India's healthcare infrastructure, improves accessibility and efficiency, and it is a move towards a digital India in healthcare. Now, who it is actually going to help the most? Now, it is going to help the most the rural workers, they're the labor class, the senior citizens, because many people don't know, especially you can say the lesser educated, the ones who are not very apprised with the medical history. You have an allergy, you are hepatitis positive. In District Bathinda, we are uploading all the reports of hepatitis C and B positive on Abha IDs, on the patient's Abha ID, and we are doing it since January. So all viral hepatitis patients who are positive, their history is in their Abha IDs. So we're trying to ensure that any drug allergy, any disease, any medical record, we are uploading it, and what we expect from the private sector. I especially request IMA of all districts and IMA Punjab to, I just was speaking about HFR, all clinics, nursing homes, hospitals. You should all get enrolled into it, make an HFR, make your IDs, and please start registering or securing the data of your patients on this app so that it helps you, your patients, and once your patient comes to you, and private and government both में होता है, डॉक्टर साहब पर्ची का कार्ड ले आए, टेस्ट घर रह गए, ECG घर रह गई. That is something very common. So I think that will save your time. You can just open on your desktop and you'll have the whole record of the patient. So that's what we want from all of you, and all of you being doctors, and I think all senior, Dr. Tyar Singh has the hospital is also already registered on it, and many have already promised yesterday that we'll be doing it in Bathinda. from outside Bathinda also, I would request that to be done. Thank you. Thank you.
Thank you, ma'am, for very crisp and elaborate. Ma'am, please stay on the stage. I would request Dr. Rajinder Sharma, past President IMA Punjab, to felicitate Dr. Usha for such an informative talk. It's need of an hour. Welcome, sir. Thank you, ma'am. Thank you, sir. So we'll move on to our next, we'll continue with our academy section with the next topic.
Good morning, everyone. I am Kushan Goyal, a first-year MBBS student at AIMS Bathinda. Next, I would like to welcome the chairpersons for the next session. Dr. Pramod Goyal, Principal, Adesh Institute of Medical Sciences and Research. Dr. Ajit Pal Singh, retired civil surgeon, and Dr. Sanjeev Mittal, leading physician of MOPA. With great enthusiasm, I would like to welcome our next guest speaker, Dr. Sushil Kotru, Chairman, Center for Excellence in Endocrinology, Diabetes and Obesity, and Principal Medical Advisor for PAR Group of Hospitals. He has written many papers published in national and international journals. Sir will be addressing us on the topic why obesity is a chronic disease, tirzepatide versus semaglutide, comparison from head-to-head trials.
I would request our chairpersons to keep a note of the time. Speakers टाइम से ऊपर जा रहे हैं. आपके सामने स्क्रीन पे भी टाइम चल रहा है. जब 5 मिनट या 3 मिनट whatever feels comfortable to you, please let speaker को बता दें. Because he is engrossed in his talk, उनका ध्यान नहीं जा पा रहा है टाइम पे. Thank you.
So we all know that obesity is the very main cause of the main diabetes and heart disease, joint problems and a lot of other diseases. The main treatment what we know is diet and exercise. But let's listen from Dr. Kodru what other things other than the diet and exercise, how we can manage the obesity.
Good morning, ladies and gentlemen. And with the permission of the chairpersons, can I start my discussion? Okay. So I'm going to deliver a talk on a very, very important subject, that is obesity. And as all of us know, it has reached to an epidemic right now. And Punjab is right now at the #1 state if I talk about obesity. And this is not the total amount of fat, it's the type of fat what we have. And if we see our bellies, we all have abdominal obesity. दिया है बटेक्स वाली रीजन का, वहां आपको भी सर्कमफ्रेंस देना है। और वेस्ट प्रेशर इट इज मोर देन 0.9 और 0.8 इन वुमेन, देन वी आर ओबीस। और आजकल हमारे पास वी हैव बॉडी कंपोजिशन एनालाइजर्स इन एम्स, वी हैव अ डेक्सा बॉडी होल बॉडी डेक्सा एनालिसिस आल्सो। तो ये हमारा टोटल बॉडी फैट बताता है। तो एंड वी हैव सिंपल मशीन्स आल्सो which tells us total body में fat कितना है. It is more than 25% in men and more than 30% in women, then we are obese. But BMI criteria, waist circumference, waist ratio, or the simple test what we should do for ourselves also, for the patients who are coming in our OPDs to label whether the patient has obesity or not. पहले बोलते थे कि obesity is only because हमने ज्यादा खाया, कम exercise किया. It is not like that. आपने आधे लोग देखे कि कुछ एक्सरसाइज नहीं करते, इतना खाते हैं फिर भी वो ओबीस नहीं होते। आधे लोग बोलते हैं डॉक्टर साहब मैं तो इतनी एक्सरसाइज करता हूँ, जिमिंग करता हूँ, डेली 10 किलोमीटर वॉक करता हूँ और कुछ नहीं खाता, मैं ओबीस हो रहा हूँ। कुछ फैमिलीज, ऑल द फैमिली मेंबर्स आर ओबीस। सो इट इज नॉट ओनली अबाउट the older theory that हमने ज्यादा खाया, कम काम किया. It's not only because of that. There are genetic factors, there are epigenetic factors, there are behavioral factors, there are environmental factors. And there are neuronal and hormonal factors. हमारा brain control करता है सब obesity को. Let us start with hypothalamus. Hypothalamus, there are centers which are important for homeostatic eating. Homeostatic means normal physiological function करने के लिए, चलने फिरने के लिए, body temperature maintain करने के लिए, physiological functions of heart, kidney, liver को काम करने के लिए हमें कुछ energy चाहिए. That is being controlled by hypothalamus for satiety appetite. If there is problem with that hypothalamus center, हम ज़्यादा खाएंगे. The other is benzolimbic system. इसको बोलते हैं hedonic eating. हमने पूरा खाना खा लिया, अब हमारे पास हलवा आ गया, हमारे पास गुलाब जामुन आ गया, हम उसको भी खा लेते हैं. Craving, liking, wanting. तो ये हमारे पास रोज हम शाम को डिनर खाते हैं स्वीडिश लाओ. मीन्स हमारा पेट भरा हुआ है, फिर भी हम वो चीज खाएंगे जो चीज खराब भी है, एक्स्ट्रा कैलोरीज भी है, शुगर भी उखा लेंगे. Then there is prefrontal cortex. This is important for inhibitory control and self regulation. भाई 2 बजे खाना है, 4 बजे खाना, भले भूख हो या ना हो, बस कितने बजे खाना है, खाना ही खाना है. तो ये तीनों चीजें they play very important role. So there are neuronal mechanisms which play very important role in weight gain, and there are hormonal factors also. जब हम खाना खाते हैं तो पेट में कुछ हार्मोन्स निकलते हैं, GLP, GIP, which suppresses appetite. अगर GLP, GIP हमारा कम हो गया, हम ज्यादा खाएंगे. हमारे पास हंगर हार्मोन है ग्रेलिन, अगर वो बढ़ेगा तो जिनका वेट गेन है, देयर इज प्रॉब्लम विद दीज हार्मोन्स, देयर इज प्रॉब्लम विद दीज न्यूरोनल सिग्नल्स. तो ये खाली ज्यादा खाने से ये देयर आर सम प्रॉब्लम्स विद द ब्रेन, देयर आर सम प्रॉब्लम्स विद द हार्मोन्स. सो वी वांट ड्रग्स, वी शुड वर्क एट दीज लेवल्स. सो व्हाट इज ओबेसिटी? हमारे पास वी हैव इंक्रीज नंबर ऑफ एडिपोज सेल्स, बट वी हैव एबनॉर्मल एडिपोज सेल्स. जो एबनॉर्मल एडिपोज सेल्स एंड एबनॉर्मल साइट्स. एबनॉर्मल साइट्स क्या मींस? एक तो हो गया विस्टल. विस्टल मींस रेट्रोपेरिटोनियल. ओमेंटल, जिसको हम बोलते हैं ओमेंटल है, विस्टल है, मेजेंट्रिक है. दिस इज विस्टल फैट. देन वी हैव एक्टोपिक फैट. एक्टोपिक फैट का होता है लिवर में होता है. फैटी लिवर, you do the scan, you will have fatty liver. And the most common cause of cirrhosis is not alcohol, not hepatitis C, it is fatty liver disease. And उसके बाद हो गया हमारे पास renal fat होता है, pancreatic fat होता है. We have ectopic fat, we have visceral fat, which is more than the Western population, and these fat cells are abnormal fat cells. These create some cytokines, TNF, interleukin-1. These cause insulin resistance and these cause inflammation. So obesity is an inflammatory disorder. अब सारे मोटे लोग, obese लोग हैं, सबको ट्रीट करना है कि नहीं करना? We have healthy obese and non-healthy obese. Healthy obese means किसी का वेट ज्यादा है बट उसको कोई प्रॉब्लम नहीं है. डॉक्टर साहब मेरा वेट तो 100 kg है, मेरा BMI 40 है, बट मुझे कोई प्रॉब्लम नहीं है. दूसरा पेशेंट है, उसका वेट 90 kg है, BMI 37 है, बट उसको अनकंट्रोल्ड डायबिटीज है, अनकंट्रोल्ड ब्लड प्रेशर है, उसको फैटी लिवर डिजीज है, उसको नीज की प्रॉब्लम है, उसको स्नोरिंग है, डे टाइम वो गाड़ी चलाते ही सो जाता है, एक्सीडेंट्स का प्रोन है. The commonest cause of accidents is not alcohol, it is OSA leading to daytime somnolence. तो इनको obese patients को OSA होता है. OSA is the commonest cause of more accidents is because of OSA. तो इसलिए अब healthy obese है, non healthy obese है. तो non healthy obese अगर है, obesity के साथ आपको comorbid conditions है, uncontrolled diabetes, uncontrolled blood pressure, OSA, multiple issues, then these patients should be treated first. A healthy obese है, इनको lifestyle intervention बता सकते हैं. और लाइफस्टाइल इंटरवेंशन के साथ वो पेशेंट चल ही नहीं सकता, क्या बोलेंगे? इनको नीज खराब हो चुके हैं, ओएसए है, डिस्नी ऑन एक्सर्शन है, मल्टीपल कोमॉर्बिड कंडीशंस हैं, इसको एडवांटन ओबेसिटी स्टेजिंग सिस्टम बोलते हैं। खाली ओबेसिटी के साथ हमें देखना और क्या बीमारियां कोमॉर्बिड कंडीशंस हैं, सो एज which patients to treat aggressively, which patient to treat with lifestyle intervention. So obesity management protocols, first is lifestyle medication. Lifestyle modification तो सबको ही चाहिए. It's very easy to say, very tough to implement. तो patient की अंतरात्मा को change करना बहुत is a very tough job. It requires a lot of counseling and behavior change. Pharmacotherapy किनको दवाई बोलोगे? आज पहले हमारे पास ट्रीटमेंट ही नहीं था. पहले obesity में लेक्चर्स ही नहीं होते थे. What we had? पहले जो हमारे ड्रग्स थे हेरिमोनाबेंड एंड साइबुट्रामिन ऑल दैट, वो बैन हो गए. उनमें इतने किसी की कार्डियक कॉम्प्लिकेशन, किसी का स्ट्रोक, जो हम खाना खाते फैट वो इनहिबिट 27 एंड पेशेंट को कोई कोमॉर्बिड कंडीशन है, 27 से ज्यादा ओबीस हो गया, अगर कोई कोमॉर्बिड कंडीशन है, डायबिटीज, हाइपरटेंशन है, हम उसको ये दे सकते हैं ट्रीटमेंट. बट वी आर गोइंग टू टॉक अबाउट टिजिपेटाइड और मंजारो. और दूसरा है अगर ओबेसिटी 30 से ज्यादा है, बीएमआई और कोई कोमॉर्बिड कंडीशन नहीं, तभी दे सकते हैं. सो क्राइटेरिया क्या है? 27 से ज्यादा कोमॉर्बिड कंडीशन है दीजिए, या 30 से ज्यादा है कोमॉर्बिड कंडीशन नहीं, तभी दे सकते हैं. एंड इफ वी टॉक अबाउट बेरियाट्रिक सर्जरी, इसका जो क्राइटेरिया है मोर देन 30 विद कोमॉर्बिड कंडीशन, अबाउट 35 विदाउट एनी कोमॉर्बिड कंडीशन. सो लाइफस्टाइल इंटरवेंशंस इज वेरी इजी टू से. डाइट करिए, low calorie diet, low carb diet. So no other diets, Mediterranean diet, Atkins diet, keto diet. We do not have long-term studies with these diets. Please don't go for these fancy diets or intermittent fasting diets. Simple low calorie and low carb diet. Our diet is rich in carbs, वो भी refined carbs. 70 to 80% हमारे डाइट में carbs हैं. 70 to 80% हमारे डाइट में carbs हैं. So once in the morning you take chapatis. Chapati क्या है? There is no bran. There is no protein. We take milk tea. Lactose है, glucose ही है, disaccharide. और हम ये चीजें लेते हैं. तो our diet is full of carbs. हमें 1 ग्राम पर केजी बॉडी वेट प्रोटीन चाहिए. अगर I am 60 kgs of weight, I should take 60 grams of protein. जब मैं कैलकुलेट करता हूँ, I am taking 30 grams of protein. Mostly we are vegetarian. So हमारे पास प्रोटीन नहीं है. It is rich in carbs and fats क्या unhealthy fats. There are lots of trans fats, lots of unsaturated fats. It's better to take healthy fats like हमने nuts हैं, seeds हैं, ये वाला fat ज़्यादा better है. So what I want to say, हमारा diet, we have to change our diet is very very important. हमारे घर में बच्चों से लेके junk foods और ये जो on order आते हैं, we have to stop that. Plaques, atherosclerotic plaques develop होता है बच्चों में at the age of 5 to 7 years. जो the junk food what they are taking. And physical activity for obese patients should be at least 60 minutes per day, at least 5 days a week. 300 minutes का physical activity in the form of any physical activity. Aerobic क्या होता है? Walking, jogging, swimming, cycling, these are all aerobic activities. But aerobic activity से खाली काम नहीं चलेगा. हमारी मसल मास कम होता है. जब वेट लॉस के लिए जाओगे, सार्कोपीनिया हो जाएगा, आपका मसल लॉस भी कम हो जाएगा, फैट लॉस भी कम होगा. ग्लूटाइड से जो वेट लॉस हुआ इट वाज 15.4%, 15 सो ट्रिजिपेटाइड और मंजारो उससे 22 केजी है, 100 किलो से डायबिटीज, अगर डायबिटीज में यूज करेंगे विच इज बेटर ड्रग, शी इज जानवी, शी इज ओबीस आल्सो, शी इज डायबिटीज आल्सो. अब इन व्हाट इज द एविडेंस टू शो कि क्या है, ट्रिजिपेटाइड जो यूज करते हैं और सेमाग्लूटाइड डायबिटीज, इसमें ओजेम्पिक यूज करते हैं डायबिटीज में. ओजेम्पिक का मैक्सिमम डोज डायबिटीज में 1 मिलीग्राम, तो 1 मिलीग्राम यूज करेंगे और ट्रिजिपेटाइड यूज करेंगे. लेट्स सी. तो इसमें हमने ये बेसलाइन कैरेक्टरिस्टिक्स है. H1C इतना था बेसलाइन पे, डायबिटीज इतना ड्यूरेशन था, BMI वाज वेरी हाई, 80 पेशेंट एनरोल किए. यू कैन सी एक तो हमें एक को 2.5 से स्टार्ट करते हैं ट्रिजिपेटाइड, फिर 5 मिलीग्राम इज द मेंटेनेंस डोज, एक को 10 मिलीग्राम तक ले गए, एक को 15 मिलीग्राम. दिस इज मैक्सिमम टॉलरेटेड डोज. कुछ पेशेंट्स ने 5 मिलीग्राम टॉलरेट किया, इसने 10 मिलीग्राम, इसने 15 मिलीग्राम, और यहाँ से हमने सेमाग्लूटाइड 1 मिलीग्राम 4 वीक्स, उसके बाद जो मेंटेनेंस डोज है. तो पेशेंट को हमने फॉलो किया आफ्टर 40 वीक्स. लेट्स सी द रेस्पॉन्स. पेशेंट को डायबिटीज भी था, वेट भी है, बट वी वांट टू सी 5 मिलीग्राम ट्रिजिपेटाइड से इतना HbA1c कम हुआ 2.1% फ्रॉम बेसलाइन. 10 मिलीग्राम से इतना वेट H1C का देखो कितना 1.9. तो सेमाग्लूटाइड से खाली 1.9 HbA1c हुआ विद मैक्सिमम टॉलरेटेड डोज, H1C कम ज्यादा हुआ. सो दिस शोज दैट इन डायबिटीज ट्रिजिपेटाइड causes much more lowering of HbA1c in comparison to semaglutide.
Dr. Kodru, 5 minutes left. 5 minutes.
Actually, I was given 40 minutes for this lecture, but I will complete in 20 minutes only. Is 25? Is 25? Okay. So with the permission, can I continue? So now you can see here also. Now talking about इनका हमें वेट भी कम करना था और साथ में हमें शुगर भी. most of the patients tolerate and this is a wonder drug. जैसे weight loss होता है, patient becomes motivated, they start doing all the physical activities, it reverses everything. We have more than 300 patients and we are the most prescribers of Manjaro in northern India, but this is extraordinary drug. महंगा है लेकिन जो पेशेंट लेते हैं, दिस इज कॉस्ट इफेक्टिव ड्रग, और इससे रिवर्स डायबिटीज, हाइपरटेंशन है, इनकी क्वालिटी ऑफ लाइफ इतनी इंप्रूव होती है, वो चीज इंपॉर्टेंट है. एंड जस्ट टू समराइज जो मैंने बताया था अभी तक, ट्रिजिपेटाइड मैक्सिमम टॉलरेटेड डोज 10 और 15 डेमोन्स्ट्रेटेड स्पिरिट वेट रिडक्शन वर्सेस इंजेक्शन सेमाग्लूटाइड 1.7 और 2.4 मिलीग्राम. ट्रिजिपेटाइड स्पिरिट HbA1c वेट रिडक्शन इन कंपैरिजन टू इंजेक्शन सेमाग्लूटाइड. तो कैसे स्टार्ट करना, अब आपको पेशेंट को स्टार्ट करना, तो सबसे इंपॉर्टेंट कैसे स्टार्ट करना. फर्स्ट 4 वीक्स 2.5 मिलीग्राम, फिर नेक्स्ट 4 वीक्स 5 मिलीग्राम, फिर 7.5 पर वीक लगेगा इंजेक्शन है, 10, 12.5, 15. इट्स नॉट नेसेसरी हर किसी को इतना डोज आए. अगर 7.5 पेशेंट स्टेबल है, 10 पे जाने पे नाउजिया वोमिटिंग हो रही, कैन कंटिन्यू 7.5. अगर 5 मिलीग्राम पे ही पेशेंट ठीक है, उसको लगता है डोज बढ़ाने से नाउजिया वोमिटिंग है, डिस्कम्फर्ट हो रहा है, यू कैन कंटिन्यू 5, बट 5 इज एटलीस्ट द मेंटेनेंस डोज. So it's very important. And those patients who are already on metformin, you can add this drug. Patient on sulfonylurea or insulin, you can add this drug. But उसका डोज कम करना पड़ेगा आपको sulfonylurea का insulin का, क्योंकि once we add this drug, इसका अपना efficacy है. At that time you might have to stop insulin or sulfonylurea. And CKD, CLD patients, elderly patients में no dose titration is required. Patient बोलते हैं इनका किडनी प्रॉब्लम है, इनका लिवर प्रॉब्लम है, ये ओल्ड एज है, क्या डोज कम करना पड़ेगा, नहीं करना पड़ेगा. एक्सेप्ट एंड स्टेज किडनी फेलियर में, एंड स्टेज लिवर फेलियर में, डोंट यूज दिस ड्रग. एंड कुछ इंपॉर्टेंट चीज है इन take care of acute pancreatitis. Don't use this drug in patients of acute pancreatitis. Once you use this drug, if a patient develops acute pancreatitis, you have to stop this drug. And pregnancy, we don't have any evidence to show that it can be used in pregnancy or breastfeeding babies. And patients with diabetic retinopathy also should screen for diabetic retinopathy. So कुछ चीजें ध्यान रखनी है जब ये किसी पेशेंट को आपने एडवाइस कर दिया, उनको बोला थोड़ा थोड़ा करके खाए. इकट्ठे खाएंगे तो वोमिट कर देगा, थोड़ा थोड़ा करके खाना. वैसे सबके लिए यही बताते हैं हम. एक बार पेट भर गया तो और ज्यादा नहीं खाना है, वैसे खाने नहीं देगा. ये लेने के बाद पेशेंट को ज्यादा खाने नहीं देता ये. और बिना वजह भूखे नहीं हो तो खाना नहीं खाना, वोमिट हो जाएगा. आपको भूख नहीं लग रही है, खाने की कोशिश करोगे, स्टे हाइड्रेटेड, टेक लॉट ऑफ वाटर, अवॉइड हाई फैट और स्पाइसी फूड्स, फ्राइड तला हुआ ये जो है, अभी भी पूड़ियां थी बाहर. नेक्स्ट टाइम सर वी शुड कीप हेल्दी फूड इन आवर मेन्यू ना डॉक्टर विकास. वी शुड कीप हेल्दी फूड आइटम्स इन आवर मेन्यू ऑल्सो. And alcohol and fizzy drinks we should avoid these. मिस हो जाता तो मंडे ट्यूसडे वेडनेसडे 4th day तक लगा सकते हैं, but after that don't inject this as per schedule. Next Sunday को ही लगाना है. This is very, very important. So if I summarize today's presentation, we should first recognize that obesity is a disease, it's a serious disease, it's a complex disease, it's a chronic disease, and it requires personalized management to address serious implications and challenges. And it is classified as a chronic disease by all the top health societies of world, like WHO and AMA also. Prevalence, the global obesity epidemic is escalating, like in India also, in Punjab also, with staggering rates in countries like US and India. Pathophysiology, obesity results from a complex interplay of genetic factors. We have some genetic genes, and once they are exposed to the environmental factors, they express themselves. Socio-cultural, behavioral factors leading to severe metabolic, biomechanical, and psychosocial health issues. Management means comprehensive obesity management strategies like personalized lifestyle changes. Personalized, it should be personalized. Targeted pharmacotherapy and surgical interventions like I told you, metabolic bariatric surgery, MBS. Tailored.
That he has mentioned detail. So any question we can have? Dr. Purabinda?
That Ozempic is causing long-term paralysis of the gut system. Like crazy, medical professionals for obesity, take Manjaro. But is there any long-term studies which has compiled the paralysis of the gut or the stomach or the nausea, long-term complications of these things, are there available in the studies which we are telling the patients or not? Sorry. This is my first question. The second question is, now the studies have come up, since it's a very costly drug, they say over a period of, you have shown, 3 years, 72 weeks, there is a 22% weight loss regarding Manjaro, right? But when they say, when you stop taking this drug, within a period of 3 months or 6 months, there is a weight gain of 82% again for the patients. And it's a very haphazard weight gain for the patient. So it has to be a very long-term prescription for the drug, and how to manage that cost and the things for the patient basically.
Thank you for these two wonderful questions. First is that long-term adverse effects of this drug. कोई भी weight loss अगर आप करते हैं, आप डाइट एक्सरसाइज से भी करोगे या ड्रग से भी करोगे, weight loss में fat loss भी होगा, आपका muscle loss भी होगा. To prevent that muscle loss, sarcopenia, it's very, very important. आपको डाइट में प्रोटीन बढ़ाना पड़ेगा. Instead of 1 gram per kg, आप 1.2 gram per kg भी important. At the same time, weight bearing exercises हमारी है ही नहीं कुछ भी. हमें muscle strengthening exercises, resistance exercises कुछ है नहीं. It's important to increase that. So it's very important ये तो है. So for that was the answer to the first question. Long term as such कोई hearing loss इसमें डिजिपेटाइट के साथ कोई ऐसी एविडेंस नहीं है कि लॉन्ग टर्म पे हेयरिंग लॉस की कोई प्रॉब्लम्स है. वेट गेन, जैसे हमने डाइट का बताया, वंस देयर इज वेट लॉस, वंस सेम डाइट एंड एक्सरसाइज देयर इज वेट गेन. बट विद मंजारो आल्सो, वंस यू स्टॉप दैट ड्रग, देयर विल बी सम वेट गेन. So but that weight gain is not once the patient will not come back to the baseline. मतलब अगर किसी का 100 किलो वेट है, उसने 25 किलो कम किया, तो that does not mean कि उसका वापस 25 किलो वापस गेन होगा. There might be around 10 kg weight gain, but 15 kg weight loss will be maintained. That इसीलिए हम बोलते हैं कि patient should continue with this drug. But Indian scenario में हमें ये भी लगता है भाई continue करेंगे तो सब लोग afford नहीं कर पाते. This is one of the issues with this drug.
So, the thing is कि I am a bariatric surgeon. We have seen with bariatric surgery that over a 5-year period surgery, even if you do a sleeve resection or do a OMI bypass, so we, for a morbid obesity patient, we have a sustained weight loss for 5 years to 6 years down the line, right? And once the weight loss goes down to around bariatric surgeons see patients in and out in the OPD. But now, since the Manjaro has come, a lot of medical specialists have started taking consideration of these drugs instead of the surgery part nowadays. So, I am talking about the cost effectiveness and the usefulness of these drugs in regard to bariatric surgery. How effective is for the patients basically?
This is very, very important topic. I am a fan of bariatric. Increases mortality को भी तो देखना है. किसी की डेथ को बचाएगा, किसी की हार्ट अटैक को देखना है. किसी की डेथ को बचाएगा, किसी की हार्ट अटैक को बचाएगा, हार्ट फेलियर को बचाएगा, रीनल डिजीज को रिग्रेस करता है. सर
Myself, Dr. Anshul. We have not only 2 modalities, but we have third modality in the form of endotherapies. We can place balloons also. We have duodenal mucosal resurfacing also. So if the patient is willing, we can give 3 options. Number 1. Number 2, the challenge again remains the same. The relapse of obesity after the therapy is over. And what is the average duration for you in your OPD? For our set of patients, for you in your OPD, for our set of patients, what time of the duration you give Monjaro or semaglutide or tirzepatide?
So it depends on the goal. अगर patient पे 100 kg है, he wants weight loss of 15 kg. So
I think we should decide.
No, we should decide. No, मैं वही कह रहा हूँ. Patient ने बोला 15 किलो, but I tell that this is not the real goal.
Yes.
What is the real goal? What is the realistic भी होना ना? Ideal तो उसने बोल दिया. Ideal might not be possible. We have to set the realistic goal. इतना weight loss है, HbA1c इतना है, इनका मेरी medicine सब्सिडी बंद करनी है, insulin बंद करना ही बंद करना. If I reach that goal in 10 months down the line, and I can stop the drug, keep the patient. और अगर मेरे पास अभी तक जो evidence है.
That drugs delays the gastric emptying, and this leads to GI side effects in the form of
headache. If there is any further question, you can ask from Dr. Kotru during the lunch time.
Thank you. Thank you.
Inspire us. Now, I would like to request to come on stage and present a token of appreciation to our respected chairpersons.
I am not asking any question. I am not asking about anything about the pharmacological control of obesity and even the surgical and the gastroenterologist. We have 3 modalities, all have this, right? And there is no consensus. We have one consensus on one thing, that is lifestyle change and the mindset change. all the house whosoever is sitting here is a specialist of some branch. But we are lacking one branch. That is not treat the illness. We are not promoting. You go to any of Punjab, at every 5 kilometers you can see everywhere there is Burger King every day. You go to Kerala, you won't see even a single outlet on the roads. This is the change. We need to change the mindset for good health in the society, and we should start with our own society. Should lead into this house. How many of us do everyday exercise? It is just 5%.
improve ਕਰਨ ਦੀ ਸੋਚਦੇ ਹੈ ਜਾਂ ਪੇਸ਼ੈਂਟ ਨੂੰ ਇਹ ਕਹਿੰਦੇ ਆ ਕਿ ਤੂੰ ਪਤਲਾ ਹੋਏਗਾ ਤੈਨੂੰ ਬਹੁਤ ਸੋਚਦੇ ਹੈ ਜਾਂ ਪੇਸ਼ੈਂਟ ਨੂੰ ਇਹ ਕਹਿੰਦੇ ਆ ਕਿ ਤੂੰ ਪਤਲਾ ਹੋਏਗਾ ਤੈਨੂੰ ਬਹੁਤ ਲੋਕ ਕਹਿਣਗੇ ਔਰ ਪਰਿਵਾਰ ਨੂੰ ਵੀ ਅਸੀਂ ਤੇ ਮਤਲਬ ਕੰਸੋਲੀਡੇਟਡ ਨਹੀਂ ਕਰਦੇ ਨਾਲ ਆਪਣੀ ਐਜੂਕੇਸ਼ਨ ਤੇ ਇਸ ਕਰਕੇ ਅਸੀਂ ਫੇਲ ਹੋ ਜਾਂਦੇ ਥੈਂਕ ਯੂ ਸਰ
Thank you, sir, for your wise words. Now we move on to a topic that many topic IMA Punjab. And I would also like to invite Dr. Amit Agarwal. He is laparoscopic surgeon at Navjeevan Nursing Home, Bathinda. The topic will be presided by
basic theme which Mohali is also following these days. So if Mohali is developing or Panchkula is developing, it is on the theme of Chandigarh itself with a wider roads, connectivity, infrastructure development, and by keeping each and every factor in the mind that every residential sector has their own commercial premises also. So everything you just name, whatever is required for a basic lifestyle is available in the vicinity only. Development is in that kind of thing. So infrastructure wise, as I've already told you, because GAMADA, Greater Mohali Area Urban Authorities, Development Authorities is taking care of all the summits. They are arranging investment summits over there, Punjab investment summits, because that area is a destination. We are coming up with international airport, which is going to be full-fledged operational very soon in upcoming days. So, as I was telling you, connectivity-wise, it's very near. It is the first destination while going towards airport. This is the last destination on the corner of the location. And while coming up, and many more hospitals are coming up. So as many of the developments are coming up, undoubtedly in comparative to Ludhiana, Jalandhar, Amritsar, Mohali is on top. There are many reasons. It's in the neighborhood of Chandigarh. They have divided the sectors. So they are planning it in such a way like there won't be any crowd of oversupply. They are maintaining it step by step. So if we compare it with any other major cities which are developing, like infrastructure wise, so it's Gurgaon, which first comes in everyone's mind, Gurgaon and Noida. But yes, if you see Gurgaon and Noida, there are oversupply over there, and pricing are much more higher than the Tri-City. Among all the factors, again the lifestyle. Lifestyle of Chandigarh is the best one. Everyone wants a fast house. As I have already discussed with you, like developments are coming up in terms of, so community living is the best factor, the biggest factor. People are interested and moving towards higher-end societies. So IT and healthcare I have already discussed. We are expanding that location. So one location is going towards prime location, Bangalore Airport Chowk. So that will be hardly 2 minutes away from airport only. Is also wonderful because because of the demand. If residential complexes are up high and societies are coming up, they will be needing some good place to spend their time for their daily need, for their basic requirements, for their commercial things. So for their commercial activities, the location, the PR7, Airport Road, we can get, as I was telling you, we are tapping international brands. We do have some commercial options available in our society itself, as is the mixed land use. So we are coming up a very limited number of the showrooms. Along with that, we are providing leasing things by the time of possession. So the rental income starts from 6 to 9% depending upon the brands and actual availability. So for that, we can discuss in detail later on. So DKG Land Corp is basically built on vision and driven by purpose. As we all are here in Bathinda, and I've already confirmed you, like we are basically from Bathinda only, DKG Land Corp. So you must have been visited to Green City itself. So we do have 25 plus years of the experience of real estate understanding. We know what our clients want. We know how they can appreciate their property.
Minutes left, please sum up.
We know how they can find the basic appreciation. So we focus on the strategic location. As I already told you, the location is on Airport Chowk, Mohali. Limited inventory, we focus on a limited inventory so that it won't be oversupplied by the time. And undoubtedly, it will keep all these factors in the mind, so long-term vision makes very clearly. So this location works for doctors, residential investment and commercial investment. All the options we consider. So when we talk about the real estate, location matters a lot. So it's easy travel connectivity, I've already explained you. And with that high-end connectivity and high-end residential complexes, you have getting good neighborhood, high-end neighborhood. Residential, if we talk about limited supply, so obviously there will be a higher appreciation and higher rental. For commercial, because location is the bang on Airport Chowk, so you get all the connectivity and commercial activities very easily with long-term rental growth. So investment right now is basically beneficial because this is the very initial stage and early corridor for investment. As we are going a step ahead day by day, so property pricing will be higher. You will be getting the benefit for that. Rising demand day by day, because when you invest in the pre-launch stage, you get more options to invest. When you get later on stage, you get higher price and less investment opportunities. So a stable city, as I've already told you, a prime location and calculation investments. This makes a wise decision. So to put upon a light upon this, I would like to invite our Honorable Managing Director, Mr. Mohit Gupta, on this stage so that he can discuss with you in detail.
Thank you everybody. मैं सब तो पहला तो साडे डॉक्टर शाबड़ा जी का IMA का थैंक्स करता है जिन्होंने सानू ये अपॉर्चुनिटी दी और शिल्पा ने काफ़ी कुछ दस्या है। जदों भी मेरे ते कई दोस्त भी बैठे हैं डॉक्टर, जदों साडी चर्चा होंदी है हमेशा कई बार गल चलती है इन्वेस्टमेंट्स से और इन्वेस्टमेंट्स से जो गल चलती है फिर कई बार शेयर मार्केट की गल चलती है। आजकल गोल्ड सिल्वर की बहुत गल चलती है क्योंकि जो भी बंदा इन्वेस्टमेंट करता है सब तो पहला उन्होंने रिटर्न तो पहला ये होंदा है भी मेरी जिहड़ी अपनी कैपिटल है वो सेफ रहे। जिस तरीके और जदों असीं रियल स्टेट की गल करते हैं, रियल स्टेट बहुत चीज़ां ने, कई ग्रुप्स इदां दे ने जिथे बंदा जो इन्वेस्टमेंट करता है फिर उन्होंने परेशानी भी झलनी पैंदी ने। उन्हों का जोड़ा बेस है वो बेस ही इस गल ते भी जो असीं कहा वो करके देना। और मैं साडे ग्रुप वालों इंश्योर करदा असीं पहले भी जो कहने वो करके देने हैं। जो डिलीवरी का टाइम है सब तो मस्ट है डिलीवरी। कई प्रोजेक्ट्स इत्थे कई डॉक्टर्स बैठे ने मेरे दोस्त, उन्होंने भी कई जगह इन्वेस्टमेंट की और बाद की होया 5-5 साल बाद लैंड ही नहीं प्रक्योर हो सकी और जदों इन्वेस्टमेंट फिर ਬਾਹਰ ਜਾ ਕੇ ਅਸੀਂ ਕਰਦੇ ਹਾਂ ਕਿਤੇ ਰੈਵਨਿਊ ਦਾ ਡਿਸਪਿਊਟ ਕਿਤੇ ਕੁਝ ਹੋਰ, ਪਰ ਜਦੋਂ ਗਮਾਡਾ ਦੀ ਕੋਈ ਪ੍ਰਾਪਰਟੀ ਹੁੰਦੀ ਹੈ ਗਮਾਡਾ 'ਚੋਂ ਸਾਰੀਆਂ ਚੀਜ਼ਾਂ ਕਲੀਅਰ ਹੋਣ ਤੋਂ ਬਾਅਦ ਆਕਸ਼ਨ ਕਰਦੇ ਨੇ। ਬਾਕੀ ਸ਼ਿਲਪਾ ਜੀ ਨੇ ਤੁਹਾਨੂੰ ਸਾਰੀ ਗੱਲ ਸਮਝਾਈ ਹੈ। ਮੈਂ ਗਰੁੱਪ ਬਾਰੇ ਤੁਸੀਂ ਸਾਰੇ ਜਾਣਦੇ ਹੋ, ਜੋ ਬਠਿੰਡਾ ਦੇ ਨੇ ਔਰ ਜੋ ਬਾਹਰੋਂ ਆਏ ਨੇ ਉਹ ਵੀ ਇੱਥੋਂ ਪਤਾ ਕਰ ਸਕਦੇ ਨੇ। ਮੈਂ ਇਹੀ ਕਹੂੰਗਾ ਕਿ ਜੋ ਸਾਨੂੰ ਇਹ ਤੁਸੀਂ ਮੌਕਾ ਦਿੱਤਾ ਹੈ ਇੱਥੇ ਗੱਲ ਰੱਖਣ ਦਾ ਬਹੁਤ ਧੰਨਵਾਦ। ਇਨਵੈਸਟਮੈਂਟ ਹੈ ਜਿਹੜੀ ਉਹ ਸੇਵਿੰਗ ਚੋਂ ਕਰਨੀ ਹੁੰਦੀ ਹੈ ਔਰ ਉਸ ਨੂੰ ਬੰਦਾ ਸਿਕਿਉਰ ਕਰਕੇ ਚੱਲਦਾ ਹੈ। ਇੰਨਾ ਹੀ ਕਹਿੰਦਾ ਹੋਇਆ ਥੈਂਕਸ।
Thank you everyone. I would like to inform you like our help desk counter is outside. If anyone wants to discuss in detail, our friendly staff is there. You are most welcome to discuss in details. Thank you so much for your time and patience. Thank you.
Thanks for this wonderful presentation, Gupta ji. And he's right. To do investment at a safer place is very important. And I would suggest that the colonies which are PUDA approved or RERA approved, and those colonies who have got these two important licenses, only we should invest only in those colonies. And the rules now for real estate colony developments, they have become so stringent that earlier now we have seen it. Now I will discuss about two parts. Number one is investment, and secondly the health. The point you Shilpa was talking about, the ambience, location, and all that. And earlier there were no stringent rules. We have seen that no width of the those streets were there. 15 feet, 20 feet. Even we cannot park our car there. We cannot reverse our cars in those colonies. No parks, no ambience, no place to breathe. So now slowly the rules are becoming stringent by the PUDA and BDAs, and now only a particular space can be developed. You have to leave those the parks area, sufficient colony. Now recently the rule has come. Earlier these streets were 30 feet wide in colonies less than 10 acres, but now up till 10 acres the streets have to be 45 feet wide.
After 10 acres, 40 feet road?
No, after 10 acres these are 60 feet now, recent.
नहीं, 50 acres के लिए 60 feet road, approach road चाहिए.
Yeah, no, less than 10 acres these are 40 feet. The latest approach. Now what I am discussing is कि now these colonies which these developers are developing, they are as per rules. So we get space to breathe, proper parks are there, you can walk, you can do exercise in those parks, and only two conditions, PUDA approved and RERA approved colonies, only invest in those colonies. Now, second part, they are promoting tri-cities like Panchkula, Jirakpur, Mohali, Chandigarh. Chandigarh now there is no space left in Chandigarh, so the adjacent cities are being developed now. And similarly, like in Ghaziabad, Noida, those tri-cities are being developed. And these places, like those who are adjacent to Chandigarh, they have nature look with them. They are because they are at the foothills. So basically, what I want to talk is that if there is a proper air to breathe, proper space to walk, proper parks are there, and they are situated at such a place near to nature, so definitely they are going to improve the health of the residents in those colonies. So I appreciate, and of course this is a good lecture, and anybody who wants to add or ask anything from the real estate, Gupta ji.
Thank you, sir. Best regulations have to be followed, and I believe the DKG group best regulations have to be followed, and I believe the DKG group whose upcoming project is coming in whose upcoming project is coming in super luxury flats which are in trend nowadays. So I believe it's a good opportunity for investment for the doctors and everyone. So we can all explore the things and be part of the success for DKG group also. Thank you very much.
Thank you.
One another thing I would request you also, that you must have seen now Ayurveda blending with these real estate. Like in South Bangalore, there are many centers now are being developed where the people are, there is no booking for another 1 year in those places. because the people go there. Now the real estate persons, they are also getting a lot. They invest there also in those colonies or those places. So your investment is high. And secondly,
सर उसमें क्या है जो पंजाब में लैंड पार्सल कॉस्टली है और सेकेंडली जो पंजाब गवर्नमेंट की पॉलिसीज हैं इस मामले में कि आपने ये चीज ही छोड़नी है, अगर आप उसको थोड़ा बहुत भी दाएं बाएं करते हो तो वो कहते हैं जी आप अपने सी लेवल से छोड़ दो। कितने सी लेवल पे कौन बिल्डर, मतलब बहुत, जैसे हमारा ग्रुप हम बहुत सी लेवल पे वो करते हैं, मान लो 55% मिलना है, 48 पे चले गए, अब उससे नीचे आने में क्या प्रोजेक्टेड रिपोर्ट है वो सारी खराब हो जाती है। बेसिकली उसके बाद भी क्या है जो अभी 2-3 चीजें और चल रही हैं, डेवलपमेंट के बाद उसको संभालना कैसे करनी है। आपने प्रोजेक्ट बना दिया, आरडब्ल्यूए से वो कोई भी चीज मेरे को नहीं लगता भी वो सेटल हो सकती है। बिल्डर का क्या होता है, बनाई चीज दे दी और आरडब्ल्यूए को दे दी, जब तक बिल्डर का इंटरेस्ट नहीं रहेगा 10-15 साल तब तक वो प्रोजेक्ट चल ही नहीं सकता। उसके लिए भी एक अलग से बजट हर बिल्डर को जो सोच के चलता है उसको रखना पड़ता है। जो आपने अप्रूवल्स की उसकी बात की, जब आप टमाटा की साइट लेते हो उसमें आप ये मान के चलो कि 80% अप्रूवल्स उसके अंदर ही होती है। और दूसरी चीज क्या है, जैसे आपने एयर की बात की, या जैसे मैं अब बात करना चाहता था, जो हमारी साइट है बेसिकली वो 3 साइड ओपन है, फुटहिल्स हैं, 2 साइड में रोड्स हैं, तो हमने प्लानिंग भी इसीलिए तो कर रहे हैं अभी अच्छे से कि हर फ्लैट को केवल लग्जरी नहीं, हर फ्लैट को धूप के लिए, हवा के लिए कहीं और ना जाना पड़े, हर रूम में उसको विंडो खोले, अच्छी हवा मिले, अच्छी धूप मिले, चाहे हमें एरिया है जो वो कम मिल जाए, मेनली हम उसको।
One more thing I would like to highlight about this DKG Land Corp group, that the group is also very important in whom you are investing. The reliability of the partners is very important, and I know them personally, they are a very recommended partner. These people are rightly from Bathinda and presently doing business in Chandigarh, and this is the thing, we get कोई गलत होता है पर कौन तो काट साथ है जिन्होंने फिर करते हैं। Thank you Gupta ji for a nice
Thank you so much. डॉक्टर जी ਤੁਸੀਂ मैं स्टार्टिंग मेरा हमेशा थॉट ਇਹ ਰਹਿੰਦਾ ਹੈ ਵੀ ਜਦੋਂ ਕੋਈ ਵੀ ਬੰਦਾ ਘਰ ਲੈਂਦਾ ਹੈ ਚਾਹੇ ਉਹ ਘਰ ਕੇ ਤਾਂ ਤੁਹਾਡੀ ਅੱਛੀ ਅੱਗੇ ਕਮਿਟਮੈਂਟ ਹੋਵੇ।
Thank you so much, sir. Very interesting topic. We can go ahead with this all day long.
Now I would like to request our respected chairpersons to felicitate Mrs. Shilpa Asija. I also request Mr. Mohit Gupta, Director of DKG Land Corp, to be present.
ओके जी ओके सर ओके।
I would now request Dr. S.S. Brad, President IMA Faridkot, to kindly come on stage and present a token of appreciation to our respected chairpersons.
67% device battery.
With this, now we move to our next session.
MSLD, metabolic dysfunction associated steatosis liver disease, previously known as NFLD, advancements in management. We are truly privileged to learn from such an expert today. With great respect and anticipation, I invite Dr. Pawan Rawal to kindly deliver.
Thank you very much. At the outset, let me thank Punjab IMA, Dr. Chabra, and everyone for having me here. And I bring greetings from Medanta, Gurugram. So, after the extensive discussion on real, and let's pick a topic which affects everyone. So, we have a colleague sitting here, so I'll take his help also in discussion. So, we'll talk about this very, very important topic, though it's interesting as well for academicians, but not for the patients. It's called MESLD. पहले इसको NAFLD बोलते थे, fatty liver, several terms used for that. Non-alcoholic fatty liver disease से ऐसे लगता था कि ये अल्कोहल तो पीता नहीं है, but फिर भी इसको liver disease है. The corollary was good. People who were obese, who were not metabolically good, they were compared with alcoholics. And it was said that, and that has been there. Since I've been groomed in PGI Chandigarh from 2005 to 8, I've been looking Punjab for very closely, and alcoholic liver disease itself is a big issue, and we all know about that. So, problem is there is something else overpowering alcoholic liver disease, and this is called as this term called MESLD. ये सब कर क्यों दिया? Why did they choose these terms? Started with obesity, then alcohol, then combination. You know, the problem is both are there. पहले कहते थे अल्कोहल पीने से लिवर डैमेज होगा, फिर ओबेसिटी से लिवर डैमेज होगा, उसका क्या जो दोनों करता है. So this topic brought out different terms. Now ये बड़ा typical सा केस है. Everybody who practices either a physician or a pediatrician or even a gynae surgeon, diabetes, early age, maybe with a family history, slight rise in SGOT, SGPT, ultrasound कराने गया तो he found fatty liver. This is very, very characteristic. Even your relatives would ask about it. कि लोग सब की कराया था. So that's very characteristic. So this will go ahead. Why the name was changed? Why this happened is because of the reason I told you. Previously it was alcohol causing liver damage. Then came up obesity causing liver damage, and then came the combinations where the affluent societies are having both. BMI भी ज़्यादा है. Obesity भी है, alcohol भी है. So they required a different terms, and they did not want to confuse one with the other. So they came with one term called as NAFLD or MEFLD, wherein you find some evidence of fatty liver in any imaging. Maybe you do an ultrasound or you do a fibroscan or something like that. Plus there is one cardiometabolic issue there. Either your waist circumference is more, or you are obese, or your blood pressure is on the higher side, your triglycerides are high, or your HDL is on the lower side. If combined, that is called as MESLD, metabolic dysfunction associated steatotic liver disease. थोड़ा complex हो गया, but will become more specific. Now, उनका क्या करें जो दोनों पीते हैं? That is metabolic liver disease तो है ही, साथ में there is alcoholism also. So they classified it that if there is a significant amount of alcoholism present or intake present, and there is obesity with the criteria as we defined, they would be labeled as MET-ALD. The intake has been defined separately. As I said, is it really big? इसका एक lecture रखना पड़ गया पंजाब IMA conference में, because yes, it is. Out of the people who are sitting here, 30 to 35%, even more, would be having this message. And this is not here in big cities, they're across the world. The global prevalence is around 32%, and India is not far behind, especially the northern India is not far behind. The prevalence is almost same. So that means with a population of 140 crores or 150 crores, 35% is a big number to handle. And this is rising. The important is, the reason we know, the obesity is rising, alcoholism is rising, so not even MET-ALD is rising, the MESLD is also rising gradually. Then it progresses. Suppose you find a person, or like we do an ultrasound abdomen and we find a fatty liver. The habit is, koi gal nahi, saare mein ho janda hai, chhad de. That is a problem. I think we should stop doing this. Fatty liver is not always benign. आज कुछ नहीं है because symptomatic नहीं है बंदा, नहीं है. Fatty liver grade 1 सबको मिलता है तो डिक्टेम हो गया कि छड़ दे, कोई को भी कहते हैं, क्लीक्स को भी कह देते हैं. But it's not the case. 25% of these people would be going to a stage called as cirrhosis. The issue is it's slow and hidden. It doesn't give you symptoms. So directly you detect cirrhosis. So let's stop doing this because of this pathophysiology and natural history. Risk factor, who develops? Of course, many are known. Metabolic syndrome we talked about, obesity we talked about. There are certain medications which can cause. Then there are certain systemic disorders which can cause fatty liver and this thing. Not going in detail of pathogenesis because it's not the need of the hour today. But simple funda, ज़्यादा fat शरीर में, more fat in the liver, more fatty acid, more oxidation, more inflammation. And we know that whenever there is inflammation and injury in the liver, body will react. कहीं भी चोट लगती है, body इसको heal करती है in the form of scar. So when there is inflammation in the liver, body will heal in the form of scar. वो scar is called as cirrhosis. And we know because we are not taking away the inflammation, the fatty liver persists throughout life. Ultimately, there is a lot of scarring leading to this term called as cirrhosis. This is in simpler terms. ये बहुत important है, busy है, but message इस study ने ये दिया that suppose you have 40 crore people having fatty liver. सारा को कैसे पकड़ेंगे? सबका इलाज कैसे करेंगे? सबको स्क्रीन कैसे करेंगे? They said that everybody is not important. उनमें से जो 20-25% जिनको fibrosis होने के चांस हैं, they are important for us. So that would mean fibrosis is the driver of morbidity and mortality in fatty liver. So out of 100 people who have fatty liver, those many people, if you can catch them any which way that they will develop fibrosis, they are actually your targets. Targets बाकी भी हैं, but बाकियों में you have to just tell them lifestyle modification. But then these are the potentials. Once the next 5 to 10 years, they will present to you with cirrhosis. And believe me, as gastroenterologist, he would agree. We are left with only managing complications. एक बार cirrhosis करके आ गया, हमारे पास उसकी ascites, उसकी encephalopathy, GI bleed manage करने के अलावा कुछ बचता नहीं है. So that's why the focus goes on primary care physician, secondary care physician, tertiary care general physician, because majority of metabolic syndrome is dealt by you guys rather than us. And let me tell you, there is no anti-fibrotic drug. Reverse cirrhosis आने के बाद reverse नहीं होगा हमसे. So that's why I think this topic was put up by Dr. Chavda here to talk about it. So इतना करके discussion ये तो पता चल गया problem बहुत बड़ी है भी मुश्किल करना क्या. Now with the context I've set, ये तो sure है हम सबको नहीं ठीक कर सकते. 40 करोड़ 50 करोड़ लोगों को तो पकड़ना बड़ा मुश्किल है. So that means अब हमारी पिछली स्टडी में जाएं, हम इसको पकड़ें जिनको फाइब्रोसिस हो सकता है. तो किसी तरह से if we can catch them early or we can segregate them from other people who have no tendency to develop fibrosis, that will be helpful. At least this is acceptable. So that means we have to catch high risk situation. That means वो situation जिसमें fibrosis वाला fatty liver हो, वो बंदे जिनके अंदर fatty liver के अंदर fibrosis develop हो, तो high risk people among those situations, and catch them early and intervene. This in principle, सिद्धांतिक तौर पे ऐसे लगता है कि this would work. So how do we go at? So that means first is risk identification. These सारे, if we are suppose 80 people around, I would find out those people who have aggressive metabolic syndrome. I have to catch them. That means the diabetics, those hypertensives, those dyslipidemic people, those people who had history or their family history of cirrhosis because of metabolic associated cirrhotic liver disease. तो ये वो सब ग्रुप उसको हम पकड़ लेंगे. And of course we'll ask the history of alcoholism also, because you know medicine is not mathematics. If somebody is obese and is taking alcohol as well, 2 + 2 4 कहीं नहीं है. 2 + 2 5 6 7 कुछ भी हो सकता है. Because once there is metabolic cirrhotic liver disease, liver already damaged है, फिर alcohol में कुछ safe नहीं है. Many people they ask you in OPD, डॉक्टर साहब थोड़ा दस दो कितना लेना, मेरे को कुछ होए ना. 2 पैग लेना, 3 पैग लेना, कितने दिन लेना. See, if you are obese, there is nothing safe. Then it goes off. So we have to take the history of alcoholism as well. The problem is this: there is no symptom. There is no symptom of metabolic cirrhotic liver disease. This is just a finding in majority. So that actually creates a problem. And the symptom, when they come, you are usually late. The person will be either cirrhotic or he will present the complications. Now come back. So suppose we set a context in our OPD that I see 100 patients in a day. Suppose उनमें से हम अंदाजा मान के चलते हैं 30 से 40% को फैटी लिवर होएगा. अब मेरे को ये पता है कि उनमें से 20% को फाइब्रोसिस होने के चांस है. उसमें से मैंने हाई रिस्क कंडीशंस को पहले देख लिया. I started identifying diabetes, hypertension, dyslipidemias, and I've started taking histories. Next step क्या है? How do I definitely know कि वो सारे के सारे रिस्क में हैं? That means we have to give some objective evidence to this. Isn't it? So that objective evidence के लिए फाइब्रो स्कैन तो है नहीं. मैं पेरिफेरी में चला गया, अल्ट्रासाउंड भी नहीं है. So then there are certain non-invasive tests. That means कुछ ऐसे blood tests available हैं. If you do them in your OPD, you can diagnose to the accuracy of 80 to 90% कि फलाने बंदे में fibrosis होएगा, फलाने में नहीं होएगा. So that is called as FIB4. इसमें कुछ भी नहीं है. We do very routinely. We need age, we need AST, ALT, and we need platelets. Very simple formula, online available है. ये तीन चीजें आपने डालनी है और आपने अपने पेशेंट को कैटेगराइज कर देना है कि वो किस रिस्क में आता है. That means either in the low risk, अगर आपका FIB4 कम है, intermediate risk if it is in the medium range, and the high risk. So at least you have done this in your OPD chamber that this guy is among the high risk of developing fibrosis. Now, अगर वो high risk है, of course he deserves a referral. Because ultimately next 2 year, 3 year, 4 year, he'll go in cirrhosis. I think he should go to him. And he has to carry out this investigation and management. Probably if he's intermediate range, which are majority are intermediate or low, you can manage in your center by lifestyle changes we'll talk about. Now, suppose आपको लगता है कि ये चीजें confirm नहीं हुई हैं, I have to do a confirmation, तो at least you saved so many people for getting fibroscan. आपने बहुत सारे लोगों को तो FIB4 से ही निपटा दिया है, बाकी बचे हुए कुछ लोगों को you have to send to this test called fibroscan, which not only tells the quantity of fat in your liver, it tells what the 90% ये बता देता है, ultrasound में है, उसको it quantifies. So it gives you a value available in ultrasound as well. If there are radiologists around, they would be knowing. You can do with a test called as RFE, acoustic radiation force impulse. It's a shear wave elastography. RFE, acoustic radiation force impulse. It's a shear wave elastography introduced in the ultrasound machine, almost equally sensitive as compared to the fibroscan. In the ultrasound machine, almost equally sensitive as compared to the fibroscan, is available. MR usually is not required. Liver biopsy करनी नहीं पड़ती out of the clinic of talk about. So let's go to the topic of interest. आगे कैसे करें? बंदा ढूंढ लिया. आगे कैसे करें? बंदा ढूंढ लिया, फाइब्रोसिस वाले को अलग कर दिया, कंफर्म कर दिया फाइब्रोस्कैन में, तो फाइब्रोसिस आ गया F3, intermediate kind of fibrosis. Interestingly, it is seen that अगर हम 10% weight loss कर दें, that means if my expected weight is 75, I am at 85. The पंगा क्या है? होता नहीं. That's the main catch. करना कैसे? ट्राई कैसे करना? डाइटरी रिकमेंडेशन मोटा मोटा इन प्रिंसिपल लो कार्ब, लो फैट, हाई प्रोटीन डाइट, रिड्यूस द कैलोरीज. सपोज मैं अभी 3000 किलो कैलोरी खाता हूँ, आई हैव टू रिड्यूस देम बाय 30%, 750 to 1000 किलो कैलोरीज. ये सबको पता है. सैचुरेटेड फैट वाले किसमें होते हैं, सबको पता है. सॉफ्ट ड्रिंक्स में क्या होता है, सबको पता है. ये चीजें हमें अवॉइड करनी है. सो वी हैव टू गो एट एक्सरसाइज डेफिनेटली. द प्रॉब्लम इज गूगल सेज और एवरीबडी सेज कि 150 मिनट कर लो हफ्ते में. That means around 5 days a week अगर आपने किया है, that would work. But actually it doesn't work. I mean, it's always good to customize. I mean, thank you. So it works in few, but better to customize to see that it is not. Weight loss नहीं होता, सबको पता है, इसकी वजह से नहीं होता. The tongue works better than brain, so this leads to problem. Second, people don't understand they are obese. मैं सबसे पूछूं आप में से कितने obese हैं? आधों को नहीं पता हम obese हैं. Because BMI के criteria change हो गए हैं, 23 का आ गया है. So important to say and tell your patient that अपनी height लो सेंटीमीटर में, उसमें से अगर आप गिराते हो, suppose मैं 177 हूँ, उसमें से 100 निकालूंगा, that's my ideal weight. And women it's minus 105. Astonishingly, there is 165 centimeter की अगर woman है, 55 घटा दोगे, 105 घटाओगे तो 55 is the ideal, या 60 is the ideal weight. That doesn't happen. So ये obstacles को कम करना है. Next comes कि दाइयां, can we do something? This is a very common question asked. डॉक्टर साहब तुसी दसो, कुछ कर दो, दवाइयां नाल करा दो, मेरे को तो हुंदा नहीं, मैं तो पानी भी लगदा, मेरे को हर चीज लगदी है. So it's very very important thing. Actually are they there? People have tried because industry is so big, there is a lot of research. जितनी research positive है, उतनी बड़ी graveyard भी है. इतने सारे drugs आए, billions of dollars were spent and they went into graveyard. But still there's some data. In next 2-3 minutes I'll present that. विटामिन ई का डाटा अवेलेबल है, विटामिन ई का डाटा पब्लिश हुआ, बट द प्रॉब्लम इज वापस आओ, फैटी लीवर को रिवर्स कर दिया, एसजीओटी एसजीपीटी भी कम हुए, फाइब्रोसिस रिवर्स नहीं हुआ. एंड वी नो नाउ दैट फाइब्रोसिस इज द ड्राइवर. द प्रॉब्लम इज इट जस्ट अ प्लेसिबो. बंदा आपके पास आया, एसजीओटी एसजीपीटी बढ़ा हुआ था, फैटी लीवर था, आप 6 महीने बाद वो खुश तो हो गया क्योंकि ओटीपीटी कम आ गए, बट अंदर नहीं चेंज आया. सो इट वाज ट्रांजिएंट. द सेम ऑलमोस्ट हैपेंड विद द ड्रग कॉल्ड एज सारोग्लिटाजर. अवेलेबल है, सेम डाटा है. फैटी लीवर तो कम होगा, फाइब्रोसिस कम नहीं होगा. Then it came semaglutide. We all know those two drugs called Wegovy and Ozempic, which came up. And initially, in data आया था, उन्होंने बताया कि, but later on, this study was landmark study, and it said that 2024 it was published. It's still going on. It will be finished in 2029. It showed that actually it reverses fibrosis. Direct की indirect nobody knows. ये GLP-1 agonist है, GLP नहीं है. So probably it acts through a systemic pathway by decreasing obesity. So it's an anti-obesity drug, and it has been approved for the NASH or MASH as well. Next is called tirzepatide, which is of course available in the name of Monzero. It's a dual agonist. So same, it also helps in not only decreasing the obesity, also in reducing the MASH as well. रिसर्च बड़ी अच्छी हो रही है. आई नो, आई मीन ही वुड एग्री दैट पहले हम इंट्रागैस्ट्रिक बलून डालते थे, उतना वेट अब दवाइयों से हो जाता है. तो लास्ट 1 year I have not put any balloon in the stomach to lose that much of 15-20 kg. That can happen with the drugs, and there is a bright future probably. I don't know whether it's industry driven or what, but then it is happening. इस तरह से dual agonist और भी available है. Surotide is coming. This is a triple agonist. GLP पे भी काम करता है, ग्लूकागोन पे भी काम करता है, GI पे भी काम करता है. अभी तक का डाटा बड़ा प्रॉमिसिंग है. It will decrease fibrosis in 30 to 50%. So coming days, it seems that body weight loss would happen. The fibrosis would reverse with the medicines. And there is another liver-specific drug available called resmetirom. ऐसा बोलते हैं कि obesity में liver में localized hypothyroidism situation create होती है. And there is a thyroid beta receptor available which is actually modulating that. So if you give something on that thyroid beta receptor, that will help in losing weight and decreasing the fibrosis. So it's a liver-specific drug which decreases the fatty liver and fibrosis both. Though it's available in India, but it's procured from Bhutan as of now. Maybe we get it in a few days. मिलता है. Those who are जो diabetologists हैं, they know SGLT2 के बारे में थोड़ा सा data इनका भी available है. That also makes. Yeah, last 2 slides. So again, a couple of drugs available. They are coming up. It seems that they are going to help you, but finally it seems that you and your patients themselves are going to take care with lifestyle modification. That probably is going to work. Combination therapy is also probably coming. The last slide is this. ये जो हम सारे देते हैं, ursodeoxycholic acid, इस सब का कोई रोल है? नहीं है. Most of the prescription they carry urso when we are starting the drugs for the non-alcoholic fatty liver disease or MASH. Probably this is useless drug for this. Please stop prescribing this. This has no role. So concluding, ladies and gentlemen, we know NAFLD is prevalent. There is no, this is known to us now. Let's accept it. Important is acceptance. हम मान नहीं रहे इस प्रॉब्लम के बारे में. Let's accept and start doing the changes we discussed this, whether it's a diet or lifestyle. Of course, prevention is there. Pharmacotherapy has a role, but we have to use them wisely. They cannot be used in every patient. They can be used in F2 and F3 fibrosis as of now with some reversal, and we probably see that there will be a change in the next 2-3 years and we get new drugs after that. Thank you.
Thank you for the excellent talk, sir. So the most important message is we have to be sensitive. Grade 1 on a sonography report is not normal, and we should convey the message to patient also that the disease has started, and this fatty liver grade 1 in itself is a reversible disease. But once, as sir rightly has pointed out, the patient comes to us in cirrhosis stage, especially the decompensated stage, we are not able to do anything about its reversible. We can just manage the complications. So, sir, there is a small query from me. What about lean NASH? How often do you see it and how to approach it? And if any therapies are available?
Excellent question. I mean, in the want of time, I didn't touch that. Very interesting thing he asked. What is lean NASH? मतलब बंदा पतला है, लेकिन fatty liver है. The problem is with the BMI. BMI focuses on kilogram per meter square. वो आप पता है. But that actually is not a representative of your metabolic health. Not at all. People are doing away with BMI. So better is, what's the ratio of your visceral fat with the subcutaneous fat? That matters. So that's why there's a term called as fat with the subcutaneous fat. That matters. So that's why there's a term called as android obesity and a gynoid obesity. So unfortunately, males have that android obesity and who karega meri metabolic health ko rather than the absolute. They also need physical activity. So physical activity should not be only for reducing weight. It should be the maintenance as well. So to start pharmacotherapy, otherwise, the pharmacotherapy indications are same. उनमें भी अगर F2, F3 fibrosis है, so we can start those drugs. But if you talk of lifestyle intervention, physical activity works much better in them, so they should do it. But there's a very, very important term he talked.
Thank you, sir, for the nice presentation. House is open. Anybody? Sir, I think the takeaway is the obesity is a disease and it should be cured. Because
it's
obesity,
a pandemic actually.
It is a pandemic.
Worse than COVID.
Yeah, definitely. And it is the most important thing which we can do our own self, just by following a diet pattern. And diet is the most important to control the obesity rather than doing anything else. कि ਅਸੀਂ ਤਾਂ ਸਵੇਰੇ ਸੈਰ ਤੇ ਵੀ ਜਾਂਦੇ ਆ ਫਿਰ ਵੀ ਨਹੀਂ ਘਟਦਾ ਵਜਨ ਤਾਂ ਖਾਣ ਪੀਣ ਨਾਲ ਹੀ ਘਟਣਾ ਹੈ ਤੇ ਖਾਣ ਪੀਣ ਤੇ ਕੰਟਰੋਲ ਕਰਨਾ ਸਿਰਫ ਤੇ ਸਿਰਫ ਆਪਣੇ ਹੱਥ ਦੇ ਵਿੱਚ
ਇੱਕ ਜੇ ਤੁਸੀਂ ਸਮੋਸਾ ਖਾਓਗੇ, suppose you eat 2 small samosas and that has 450 calories, ਤੁਹਾਨੂੰ 2.5 ਘੰਟੇ ਚੱਲਣਾ ਪੈਣਾ ਉਹ ਕੈਲੋਰੀ ਲੂਜ਼ ਕਰਨ ਵਾਸਤੇ. We don't do that. So there is a gap. You know, people think that मैं exercise कर ली, मैं 10,000 steps पूरे कर ले. That's very odd though. No people, they don't do 10,000 steps. But after 10,000 steps, you burn hardly 350 calories. That equivalent to hardly half some. So there is a gap in thinking. हम सोच रहे होते हैं मैंने exercise कर ली, input output ratio में नहीं. That's the most important thing.
So anybody, Mike, please.
Yeah, pio and vitamin E combo. So vitamin E in 800 units for that many weeks led to decrease in SGOT-PT and fatty liver, but no effect on fibrosis. This is why. Pioglitazone was also studied. It has also the similar effect. The problem is it takes away the good effect other way around. Then there was an issue that bladder cancer, of course, that came up with that. Though it was issue with the vitamin E also. There is some risk of hemorrhagic stroke and prostatic CA, but that was nullified in nutrient studies. Interesting thing, that's the last point I will add is, there was another retrospective big study in 2019 which proved that vitamin E given in adequate doses for a long time, the rest retrospective, that cannot be given as a guideline.
Thank you, sir. Sir, since Dr. Kasliwal was coming over to Bathinda out here, the doctors, because doctors always order the test, but they never get it for themselves.
I would label it as the most wonderful test of the world.
Yeah,
Non-invasive. See, he would remember how many liver biopsies he would do. And now we are done away with the liver biopsy other than few indication of autoimmune hepatitis and others. It's a wonderful test. Here is acceptance, that is a problem.
So this PIMACON is a healthy session by Dr. Kasliwal with a fibroscan camp arranged for all of you. So do attend it. And thank you, sir, for a
Thank
wonderful
you very
talk.
much. Thank you.
Thank you so much, sir, for the insightful and comprehensive presentation. Your discussion involving definitions, risk assessment, non-invasive diagnostics, lifestyle modification strategies, and emerging therapies has certainly enhanced our understanding on this increasingly prevalent condition. May I now request our esteemed chairperson to kindly facilitate Dr. Pawan Rawal. Now I request Dr. Keshav Sood, President IIMA Hoshiarpur, to come on stage and give token of appreciation to our respected chairperson. Now we move with next proceeding.
Blindness in infancy is often preventable when detected early and managed appropriately. Retinopathy of prematurity remains one of the most significant yet manageable causes. To shed light on this screening, management and prevention, We are privileged to have with us Dr. Vanna Sharma, Associate Professor, Department of Bathinda, with fields of interest oculoplasty and corneal transplant. Dr. Gaurav Manga, Senior Ophthalmologist at Vasu Eye Care, Bathinda, as our chairpersons. I feel delighted to invite our esteemed speaker, Dr. Karamjeet Singh, Professor and Head, Department of Ophthalmology and Medical Superintendent, GMC Amritsar. Sir has done immense work in field of retina, especially in pediatric retina. I invite Dr. Singh to the dais.
Respected, I am thankful to MA Punjab for giving me opportunity to speak on this topic which is close to my heart, and also it is very much ignored in rural areas of India and also in India. So my topic is basically one of the very important disease of premature babies, that is retinopathy of prematurity. It is not in terms of economic burden, but it's a severe social implication in years. Among the preventable blindness in childhood, retinopathy of prematurity figures a very high in agenda. So what is the ROP? ROP or retinopathy of prematurity is gestational age and birth weight. So this disease, the low gestational age and birth weight, these are the most important factors that governs the severity of the disease. The very low gestational age, less than 32 weeks, and has chances of development of this ROP. So why there is a low incidence of ROP in India? It is seen in the literature that there is a low incidence of ROP in India. So this is because there is low or no survival rate in children, especially in those incidents that is unreported in the literature as well as in the health department. IUD are in view of low nutrition and anemia among the Indian mothers, which is not common in our state. Yes, among ophthalmologists and neonatologists, but these days the knowledge of ROP, it spreads a lot because it is now covered under team and lack of experience and infrastructure for screening. So basically, to understand what is retinopathy of prematurity, we should know what is the normal retinal vascular development. Details of this, but we should know that the retina of the premature babies, the blood vessels which are supplying the inner layers of the retina, they mature by 36 to 40 weeks, and it starts at 6 weeks of gestational age, and it reaches near the middle of the retina at 16 weeks, and at the posterior pole at the 32 week only. If the birth of baby occurs in between that, then that retina becomes immature, that retina behaves as immature retina, that there is no vascularization of retina at that point. So this is the basic vascularization etiology why the premature retina is there. So there are different theories. I am not going in the detail of this. Basically, there is a role of oxidative stress in the premature retina. So previously it was thought that the oxidative stress is only the reason for the development of retinopathy of prematurity, but there are so many other factors. Of course, oxygen stress, it plays a role in development of this retinopathy of prematurity. So, the role of growth factors. We all know these days, there is a lot of research on growth factors these days. These growth factors are basically vasoformative factors. Those play a role in maturation of the retina as well as the maturation of the other organs of the body like lungs, kidneys, liver, etc. So this vascular endothelial growth factors plays a role. So when there is immature retina, that retina behaves as ischemic retina. So there is abrupt release of these vasoformative factors from that immature retina. That leads to abnormal vascular formation near the immature retina, that those vessels, they basically comes forward in the vitreous cavity, and those vessels pull the retina towards the vitreous cavity that leads to retinal detachment after that blindness. So vascular endothelial growth factors, they play a very important role in ending retinopathy of prematurity. These factors, they are released from the avascular retina, which behaves as the ischemic retina. So these are the how the vascular endothelial growth factors along with other angiogenesis factors, they play a role in development of retinopathy of prematurity. There are other risk factors also. The most important are the prematurity and low birth weight. But other risk factors like hypoxia, hypotension, acidosis, respiratory distress syndrome, sepsis is very important. Sepsis after the childbirth, then anemia and repeated blood transfusions, PTA and the babies on the phototherapy. So these are the few terminologies according to the classification of retinopathy of prematurity. So there are the eye of the premature baby is divided into various zones. These are zones. These are important for treatment purpose, for the management of retinopathy of prematurity and for the classification of the severity of the disease. So basically, retina is divided into zone 1, zone 2 and zone 3. These are classification according to the international classification of the retinopathy of prematurity. And there are different stages in the development of the disease. So stage 1 is a demarcation line. Demarcation line is basically a line between the mature retina and the immature retina, which is the vascular retina. And after some time, immediately after birth, this line is visible, and after some time there is a development of a ridge. Ridge is basically towards the vitreous cavity. Then from that ridge the extraretinal proliferation starts. So which further pulls the retina towards the vitreous cavity, that leads to retinal detachment. That is the stage 4. So when the central part, the macula is involved, we say that it is stage 4A. If macula is detached, then we say that it is stage 4B. And stage 5 is total retinal detachment. These are the terminologies in severity of a disease. Plus disease is very severe disease. So this is according to the management of the disease. Then there is a term that is AROP. In our institutes, we receive the patients mostly in this aggressive disease. It is a very aggressive form of the disease. It is basically situated in zone 1, which is the central zone, or zone 2 just adjoining to the zone 1. And there are prominent vasculate vessels which are seen in the retina. So and there is also shunting of the retina along that. And sometimes we see that there is a neovascularization. That neovascularization leads to further retinal detachment and further complication of the disease. So this is basically how the retina of the baby, premature baby, look like. So in first slide you can see that there are vessels seen, and the vessels are reaching towards the far periphery. So when the vessels become thread-like, in the lower pictures, 2 pictures, when the vessels are thread-like, you can say that the retina of the baby is premature, and we have to watch this retina by simple fundoscopic examinations. And when there is a development of demarcation line, like so here you can say that there is a clear-cut demarcation line between this is avascular retina, this is the vascular retina, you can see. And here also you can see that there is a line. So that line indicates that there is avascular retina, we have to treat this retina. And in stage 2 disease, there is a formation of a clear ridge. So basically this is a picture of the eye with stage 1, stage 2, and in stage 3, along this ridge there are the vascular proliferations. You can see the abnormal vessels are there. So if the central vessels, they are very much dilated, tortuous, then you can say that this disease is very aggressive disease we have to treat this immediately. And normally this is the normal caliber of the vessels. So and these vessels when become dilated and tortuous, this needs immediate treatment. So these are the another pictures of the immature retina with the very aggressive disease. So here you find that here the retina is detached. So this disease, if we don't treat this disease at this point, so there is a total retinal detachment, and most of the times that remains untreatable. And after some time, the retina becomes like this, and this is the total retinal detachment in the babies. So these are the few diseases. So this is the fate of the immature retina at the time of birth. So retina, after we diagnose the disease, it can lead to spontaneous regression. This can lead to spontaneous regression. It can go to blinding disease, or there are vitreous hemorrhages in the inside the vitreous cavity. This can lead to some tractions in the retina. So this is severe blinding disease. This is the total retinal detachment, and these are also the aggressive forms of the disease. So how to manage retinopathy of prematurity? The most important factor in management is screening of at-risk babies, then diagnosis of the disease, and decision to treat or not to treat or to follow up. Treatment is treatment of retinopathy of prematurity itself, observation, treatment with laser or with surgery, and also correction of the systemic factors, which are very important. And treatment of retinopathy of prematurity related complications like retinal detachment, cataract if there is a formation of cataract in the babies. And also post-treatment follow-up is very important. And rehabilitation, if the treatment, if the premature baby treatment is unsuccessful or there is total blindness of the baby, then rehabilitation point is also very important. Now screening is very important. Which baby to screen? So according to Indian Academy of Pediatrics and according to the international criteria for retinopathy of prematurity, every baby born less than 2000 gram or gestational age less than 32 weeks or all preterm babies, especially in the rural belt where the gestational age is not well known. But the onus of getting the baby to the ophthalmologist is with the physician, gynecologist or with the pediatricians. Otherwise, sometimes the babies are ignored. The parents after birth, they are not directly going to the ophthalmologist for to check the baby for his or her retina. But it is very important the ophthalmologist checks only when the physician, gynecologist or pediatricians or the RMPs or the trained eye or nurse refer the baby to the ophthalmologist, because this is screening part is very important. It should be done by the ophthalmologist only, and it is very difficult to screen the retina of the premature babies. The pediatrician or gynecologist or physicians are not competent to screen the retina of the premature babies. So when to screen is very important. So it is very important that this disease, it is not present at the time of birth. It develops after birth. So as I told you that the vascular endothelial growth factor plays a role in development of the disease. So when there is avascular retina, so there is a release of vascular endothelial growth factor from that retina. It is not that from 100% immature retinas the VEGF is flowing to the vitreous cavity. So VEGF needs some time to build its concentration inside the vitreous cavity, and after that the retinopathy of prematurity starts. So day 30 strategy, which is recommended by the Indian Academy of Pediatrics and as well as International Classification of Retinopathy of Prematurity. So day 30 after birth, treatment. So this 10-week period is very important. So sometimes it is common with that those in the rural belt, सवा महीने तो पहला बच्चे को बाहर नहीं करना. That should not be there. Especially 28 days or at 1 month, the baby should be screened for retinopathy of prematurity. If we lost, it's difficult to treat that baby either with laser or with surgery. And the screening is very simple. It's very simple. So first we dilate the people, and these are the simple things which we require for dilatation and this screening. And screening is done under topical anesthesia only. There is no need to anesthetize the baby. There is no need to sedate the baby even. The premature babies or small babies, they are very cooperative. There is no need to sedate or anesthetize them. Simply put proparacan eye drops inside the eye, then we apply this small wire speculum, and after that with and 20 diopter lens with a simple manipulator, we can examine whole of the retina up to the periphery. Ophthalmologist can examine whole of the retina up to periphery. And babies are very cooperative, so where you throw the light, babies focuses the light in that direction only. Otherwise, you can manipulate the eye of the baby with the simple indenter. So this is how with interactive scope the retina look like. So this is very aggressive disease, worm-like disease, and decision to follow up is very important. So treatment is in the form of laser. So laser setup is also detachment. Then we can do retinal detachment surgery in babies also. So these days the role of anti-VEGFs. Our previous speakers, they highlighted the role of bevacizumab, ranibizumab, and aflibercept in prevention of retinopathy of prematurity, in prevention of the blinding disease of retinopathy of prematurity. We mostly use ranibizumab for treatment of in the form of injection in the intravitreal cavity for the treatment of the retinopathy of prematurity. So prevention of premature babies, and monitor oxygen saturation, vitamin E, antioxidants. So there is a role of pediatrics, a role of betamethasone or dexamethasone in antenatal period. So there should be a team approach for management of this disease. So there is a role of pediatrician implications also. So successful planning can make a difference for a lifetime of a child. Thank you very much for your patience.
Okay, and your team approach. All thanks to our senior pediatrician and friends. Because of the survival of the incidence of ROP has now
that they have to refer the child for screening on time.
Sir.
Even now, one case is going where they have demanded a compensation of rupees 12 crores. 12 crores for this ROP. So it's very important. My one suggestion to the friends is we must write in vernacular language also कि अखा दा टेस्ट इस दिन कराना है. Sometimes we write in English ROP या eye testing. Patient में से एक सानू तो दस्या ही नहीं. So that is very important. We have to make the patient understand, and we should mention even in the vernacular language. That will be good. Sir, my question is only just a clarity. What is the incidence in low birth weight babies? Prematurely we have been dealing, we have been advocating, we have been getting tests. But now this low birth weight, 2000 grams, what is the prevalence of ROP in such cases?
Sir, that ranges between, as in one of my slide I have shown, that ranges between 3.5 to 18% in Indian scenario. Because in most of the semi-urban areas and in the rural areas, there are no screening protocols, and there are less ophthalmologists available, especially that is in the border belt of Punjab. Even we are encountering the babies in stage 3 or stage 4 disease, where the severity of disease is more. There are less chances of the retina to reattach. So it is nearly, in one of our study, it is 7% in our institute in Government Medical College Amritsar.
Yes.
Also,
And another important factor is, sir, liberal use of oxygen that was previously recommended by the pediatricians. Now Indian Academy of Pediatrics recommends that there should be cautious use of oxygen to the premature babies in either neonatal intensive care units or in pediatric wards.
Sir, I think ROP term appears to be a misnomer in the way that this retinopathy can develop even weight even more than 2 kg.
Yes.
Gestation is more than 32 weeks. Yes. So in that way, it appears to be misnomer because not only premature babies, but even full-term baby can have this problem.
Sir, there are other factors.
Giving too much oxygen, mechanical ventilation, and giving blood transfusion, having sepsis, and as you said, I think phototherapy.
Yes.
Can cause retinopathy also.
Yes, sir.
But we usually cover the eyes, protect the eyes with some shield. Even then it can cause retinopathy.
Sir, it is not the direct photo injury to the retina of the premature babies. It is the oxidative stress which is induced by the phototherapy unit or by giving oxygen at higher concentration or higher doses. So there are guidelines of Indian Academy of Pediatrics. There we should use intermittent oxygenation to the baby, and also we should cover the face of the baby while giving the phototherapy. I think most of the pediatricians might agree with me that the abdominal part or legs or limbs should be uncovered while giving the phototherapy. So there are other factors also. Septicemia is a very important factor. That in one of our study, which is published in Indian Journal of Ophthalmology, after the birth weight and low gestational age, the third factor is the septicemia, and it is very common is there in babies. And after that, repeated blood transfusion, as you said. So in those babies also, the incidence is very high. And these days we are encountering the babies which are more than 2,000 grams. That's why the National Program for Control of Blindness and Visual Impairment, they incorporated the screening program in their national program or in universal screening program, health screening program by Government of India.
Another question is, under Yushman Path, people, the pediatricians, those should, I think this question should remain within the theatre, not outside. They put the baby just honor card on ventilation for say 7 days, then on CPAP, then on oxygen, say for 3 weeks. Honor card shown that the baby is teething, whether premature or full term, but actually not given. Honor card is there. What should be the status in that case? Whether we should get the ROP or not?
Sir, actually ROP screening should be done. Even most of the pediatricians in tertiary care institutes, they are writing on the card ROP screening at 28th day. So they are writing, and it is good that most of the pediatricians are writing, or they have incorporated in their health card of the baby the ROP screening. That's why we are screening more and more babies these days. But so I'm telling you, sir, even if the immature retina is present in mature babies of 2.5 gram or 2.8 grams, so there are chances that there is spontaneous 90% of those babies, even more than 90 rather, there are chances of spontaneous regression of that disease in those babies as compared to the premature babies. Actually, in premature babies, it is seen that VEGF load, the vascular endothelial growth factor load, is very high. So in low birth weight babies, the lungs of the babies, they are also immature, and we give surfactant and other substances for the maturation of that retina. That also enhances the release of VEGF inside the vitreous cavity in premature babies, and we are not giving that in mature babies. So there is one study which is published in New England Journal of Medicine. They say that surfactant and other substances that other than steroids, other than dexamethasone or betamethasone, they enhances the release of the VEGF inside the eye. That further increases the disease, or further increases the chances of the retinopathy or prematurities.
So my suggestion to the pediatrician, as Dr. Bajaj said, it should be in Punjabi or Hindi language, and we must get the sign of the attendant or the parents there on the file that we have recommended retinopathy of prematurity ROP screen. Also, I think, and I'm doing it, video recording. Yes. That the pediatrician has told us कि असी यदि अखां दी जांच करने वास्ते अखां दे डॉक्टर को भेजा गया जे किसी लिटिगेशन तो आपा बचना था. I think this is the best approach which we should do to avoid medical legal problems.
Sorry, rightly said, ROP can happen in mature babies. It all depends on the perinatal events. During the birth, what the weight. Weight is one of the important factors. Other events are also important. If some baby has a high risk history, he should be screened.
I think we should also highlight that initially, since NICU or other facilities were more approachable to people with affluent societies who could afford the treatment. But now at AIMS we are seeing more of the lower socioeconomic strata coming to us with ROP because of maternal malnutrition and more perinatal events that have happened with the child. So the socioeconomic strata now does not define the prevalence of ROP anymore.
Actually, in Europlasia, even in rural Punjab, the screening protocol started only after there are so many litigations in the High Court and Supreme Court in 2012, and there are heavy penalties. 2 or 3 times we screen the baby at their home only. So screening equipment is simple, so we can carry in a small bag also. So we can screen babies even at home of the baby.
Thank you, sir.
Thank you.
Since we are short of time, I would request chairpersons to please give a thanks about and close.
Enlightened presentation and discussion. Now I request esteemed chairpersons to felicitate Dr. Karamji. I request Dr. Bhupendra Bansal, laparoscopic surgeon at Mera Ram Hospital, to come up on the stage for felicitating the chairpersons.
How we can open level that can be given in 5 seconds. It costs 30,000 and it is made available to us. Just mapped it out. You can see that there are many important things, including defibrillators, ECG machines. Majority of the places it was not available. So we just again went to the government, which Samari help kar do, and then we got government procure.
Meeting MI.
We have that we are better off.